right, we're going to get started. If everybody will take your seat. All right, if everybody will take their seat. Now that worked. Good morning. Our first presenter this morning is going to be J. Patrick O'Neill, who is the Commissioner of the Department of Public Health. And he's the new kid on the block. And he's going to come talk to us a little bit about the department and some of the things that the department can be involved in as far as enhancing the access to health care in rural areas. So let's welcome Dr. O'Neill.
Good morning. It's really interesting to be referred to as new kid on the block. At age 75, I have to tell you, I don't feel like a new kid anymore. But I also want to share with you, to get the morning started, a comment that one of the physicians in public health made to me not too long ago. She is much younger than I, much smarter than I, and doing a great job. And a lot of the people were calling her by her first name, but they were referring to me as Dr. O'Neill. And she asked the question, she said, why do they call you Dr. O'Neill and they call me Laura? I'm a doctor too. And I didn't have an immediate answer for her, but the HR director piped up and he said, they call him Dr. O'Neill because he's old as dirt. So the new kid is old as dirt. Several things, though, that I think are terribly important. We're really happy to be here today because I think public health has a tremendous responsibility to address the issue of healthcare in Georgia. As most of you know, we are committed to healthcare and population health throughout the entire state of Georgia, not just metropolitan areas. And I think addressing the issues in rural Georgia is extraordinarily important to us. If I can figure out how to. Thank you. I only throw this up there to emphasize that our mission applies everywhere. It's not to Atlanta, it's not to Augusta, it's not to Columbus, it's not to Savannah, any more than it's to Metter, Georgia. Our mission applies everywhere that public health is. And this is just to show you that public health is in every county in the state of Georgia. Now, that doesn't mean that we're doing a great job in every county. We do have a health department in every county, we have a responsibility in every county. And one of the things that we want to try to look at is where are the gaps in those counties that we could be doing better. And these are services that public health offers in every one of our health departments. But I will tell you, I have to admit that I don't think that we offer these services to the same degree in every county that we need to be offering them. We have to acknowledge that. We have to identify where those breaks are so that we can make efforts to improve them. Child health is extraordinarily important, and at the end of my talk, I want to emphasize one of the priorities that we have related to early brain development because I think that it addresses so many of the gaps that you find not just in rural Georgia, but in other parts of Georgia as well. So from my perspective, I could be a great-grandfather by now, but I'm not. But I'm really interested in what we do for kids. And I think child health is extraordinarily critical for public health. And with that goes women's health. If we're not taking care of the mothers of these babies, then the babies aren't going to do well either. So our women's health activities in every county are also just as critical. Immunization has been my public health for years, as you know, but it's not in public health nearly as much as it used to be. Probably 85% of immunization now resides in the private sector, and that's okay. You know, we don't have any right to want to hold on to something. What we want to do is to see improvements across the board in outcomes in health in Georgia. So from my perspective, it doesn't matter who's doing it, as long as it's a capable individual doing it, the immunization needs to happen. So that's really critical, and it's a long-term effort of public health. Ryan White clinics are also extraordinarily important. And here in rural Georgia, a lot of this gets overlooked. You know, we talk about having such a heavy burden of HIV in Atlanta, and we do. 40 to 50% of HIV positive individuals live in metro Atlanta. But it's often overlooked what happens in rural Georgia. And there are unique stigma issues in rural Georgia that we don't even appreciate in the metro areas. So the Ryan White clinics are extraordinarily important down here. And there are ways that we can address that even when we cannot have a Ryan White clinic with the specialist on place. We have technology that can allow that type of consult where primary care folks can be delivering that care. Advanced practice nurses can be delivering that care. We just need more of them. Children with special needs are extraordinarily important to us, and right now I will tell you that we're making arrangements because of special needs kids that may be in the path of this hurricane that's coming our way. In public health, we have a tremendous responsibility to see that those folks get out of harm's way as quickly as possible. And their plans are afoot right now today to take care of those folks. Communicable infectious disease, I think we do that pretty well, even in rural Georgia. Not as well as we could, but we've got an extraordinary epidemiology section. Those are our disease investigators. Those are our disease detectives. And we support them tremendously. We've got a very large section of epidemiology. Some people would say compared to other states, maybe it's too large. It's not. With the disease burden we have in the state, infectious disease burden, both chronic and acute, we need every one of those folks that we have. Women's, infants, and children's are the WIC program, obviously. And at the end of the talk, I want to emphasize why that is so absolutely critical, that we see that we have adequate nutrition for those young ones that are born and basically have struggles getting adequate nutrition if it's not provided through WIC. Environmental health goes, I think, unseen by a lot of folks as part of public health. But in terms of what's going to happen in rural Georgia, this is one of the most critical things. If we don't have an adequate environmental health workforce, we're not going to have economic development. We've got to have those folks that are able to do the essential inspections so that the growth can continue. And if growth is hampered because we don't have enough of those folks in the field doing those inspections, the economy suffers. We can't afford that in Georgia. And these are just some of the inspections that you see. Swimming pools, and that's not your private pool. These are public pools that we have to inspect. And we do identify outbreaks related to public pools on a regular basis. So if those inspections were not occurring, the number of outbreaks and the potential for actual deaths as a result of that would be significant. So that's terribly important. Tourist accommodation, there are a whole host of things that we have to look for as we inspect the tourist accommodations. And I think probably the first thing that comes to mind to most folks is bed bugs. We certainly have heard and seen a lot of those. Insect disease surveillance is also important, and basically we're looking at a couple of different things. Right now, we are not only looking at individuals who have come to Georgia from travels abroad, countries that have Zika, and monitoring those individuals, especially if it happens to be a pregnant woman. But we're also even looking at the insects themselves. We now have teams of surveillance folks all across the state who are catching mosquitoes, monitoring the type of mosquitoes we have, because every mosquito doesn't transmit the same type of disease. And if we know ahead of time where the bulk of the mosquitoes are, the Aedes mosquitoes, for example, we can predict and hopefully prevent some of the issues that those types of mosquitoes spread. So that type of surveillance is really critical. And it's critical here in rural Georgia. We have outbreaks in this part of the state with eastern equine encephalitis, not uncommonly, that's carried by mosquitoes. So it's just as critical that we have that activity going on down here in Metter as we have it going on in Fulton County. Rabies control is also important. Nobody else wants to do rabies control. That's one thing that public health, and that's part of what's important to public health. We have to identify what we call essentially the core of public health, and we have to do things that we can do best. We also have to do things that nobody else wants to do, and things that have to be done to protect the population. And rabies is one of those situations. No other lab in Georgia or in the Southeast wants to take a dog's head and do the studies necessary to find out if that dog that attacked somebody had rabies or not. And that determines how we're going to treat that person who was bitten. So it's absolutely critical, and yet it's not something that anybody else wants to do. Public health has to do it. Individual water system inspections, again, that basically applies to wells. And we've got really critical situations, particularly in a belt across South Georgia, in the Waycross area that comes on and sweeps sort of in a reverse C with all sorts of chemicals that are naturally occurring in the environment, but that can be in well water. And there are filters that can be put on those wells to protect individuals so that they can still drink that water. So this is also a role of public health. Food safety inspections, I think most folks are well aware of. If we were not out there inspecting restaurants, the amount of foodborne illness in the state of Georgia would be astronomical. Even with our inspections, we still have those outbreaks. And it's the role of public health to see that that's minimized. I'm going to just leave the slide up and talk in general about EPI. I guess if I had to choose the section of public health that I think has the strongest scientific basis, it would be epidemiology. The science behind epidemiology is magnificent. I think the areas where we really shine with science are EPI, our state laboratories, and environmental health. In those areas, we are extraordinarily science-based. We've got tremendous evidence behind what we do that supports our activities. So I'm really pleased with epidemiology. And as I mentioned before, I consider epidemiologists to be disease detectives. And hopefully, they can identify situations early so that we keep them from spreading and becoming monumental. Our EPI section is absolutely critical to the success of public health. And it's just as critical in a rural area where something may go unknown for a period of time because there are not a large number of people that may be impacted by it initially. It's just as critical there that we have EPI investigations so that we can prevent the spread. And I don't know that this slide is terribly important to you because most of these things that are specialized services can only be made available in areas where you have huge populations. We do have them available, and the only reason that I allowed this slide to still be in this is because I want folks in rural Georgia to know that even though this may not be available in your area, there are opportunities through telemedicine for an IT connectivity so that you can gain some of these same benefits even if you do not have them in your own county. Expanding access. I think this is absolutely critical, and I'm sure you've heard a lot about this yesterday, and you'll continue to hear more about it today. We've got extraordinary inequity across the state of Georgia in access to health care. And as I mentioned in the beginning, I think that public health has a responsibility to address that, and not just to address it, but to find solutions to how we change that. The thing that is also changing in public health that I want to put out on the table, because this gets, from a policy perspective, this gets a lot of interest. We are in our federal grant programs, which now account for about 67% of the budget for public health, federal grants. Those federal grants continue to decrease. Every single year since 2014 that I've been following this, those numbers are going down. And the area that they're going down in primarily are grants that did allow us to use some of that funding for actual treatment. The view that came about with the Affordable Care Act, which didn't necessarily apply, was that once you had the Affordable Care Act, you wouldn't need to have any federal grants to support any treatment because everybody would be covered with insurance. Well, obviously, we know that's not the case. And even the individuals that may have some coverage, it doesn't cover everything by any means. And if you are in a section of the state where there are high poverty rates, those uncovered factors are monumental and may even stop you getting any care, period. Well, as this idea was coming out of Washington that all the federal grants could stop paying for any care delivery, and our grants started shrinking, we began realizing that we had to try to fill that gap or we couldn't continue to offer the services we were offering. So we are looking for and have found and are continuing to try to expand our ability to bill for services through insurance coverage when it's available. Public health had never done that before. You know, the idea used to be if you got into the health department, it was free. Well, nothing was ever free. You and I paid for it with our taxes. But people didn't pay out of pocket. And now what we're trying to do is to identify those situations where individuals do have some coverage that will cover at least a portion of their care that will offset what our losses are in our federal grants. And we are, in fact, trying to build a system statewide so that we can do a better job of collecting those situations. Now, that doesn't mean that we turn anybody away because they don't have coverage. In public health, we don't do that. We offer a sliding scale for those that have the ability to basically pay a portion of what their bill is. But if they don't have anything to pay, we still treat them. And that's important because a lot of those things that we're treating, if we don't treat, they spread to others. And they ultimately end up costing the state more money. So turning patients away is not an option in public health. These are the insurance carriers now that we have some relationships with. Obviously, folks immediately think of Medicaid, and Medicaid has been extraordinarily helpful in terms of working with public health in so many activities, so many programs. But we're also reaching out into the private sector for coverage as well. Enterprise systems modernization, what's that all about? That's absolutely critical for what happens in rural Georgia. Right now, we've got 18 different health districts, and they are all on separate IT systems. Now, if I need to know what the incidence of measles cases is in Metter, Georgia, I have to call down here and get somebody to look and find it. I don't have the ability to go into a system and see what the reports are. With enterprise system modernization, which is still probably another 18 months away before we have it completed, it's making a lot of progress. But when we have that, it will be a single system available throughout all health departments in the state of Georgia. Or there may be more than a single system, multiple systems, but there will be absolute connectivity in all that's out there. And that's really critical for us. It's a major undertaking. I want to thank those of you who are legislators who have supported this financially. It's over a period of probably 5 years before it's completed. And it's in concert with a lot of other activities like the IES system, the integrated eligibility system that Commissioner Crittenden has been sponsoring. All of this is to improve our ability to collect data that will drive our response. We'll know where to target our activities when we have accurate data. But it's also going to be patient-centric. We want our individual patients. And let me tell you, most individuals, even who are 7 years old, are more adept at IT than I am at age 75. So the ability to get into information systems and use that information is far greater than we give a lot of people credit for. And the system we develop needs to be very patient-friendly. This is just a list of some of the things that I think are really important in terms of enterprise system modernization. It's a heavy lift because people that have been using old systems for a long time are very reluctant to turn loose and let go. But the gains of having an integrated system are so great that we cannot allow that to stand in our way as we move forward in developing the system. And it means change. Change is always painful for a lot of people, but ultimately for the state of Georgia, this type of change is not just valuable, it's absolutely essential. And I don't know of any part of Georgia that's going to benefit any more from having this type of ability to gather data statewide than what's going to happen in rural Georgia. telehealth and telemedicine. This is an area that I see, and I only throw this map up here to have you look at the blue dots. Those blue dots indicate that there is a telemedicine connectivity in the county where the blue dot resides. From your seats, you may not be able to see that very well, but I can tell you that there is a blue dot, at least one blue dot, in many instances more than one, in every single county in Georgia, all 159 counties. We're not taking good advantage of that by any means, and we've got to. And that, I think, is one of the greatest offers that we in public health, and not just public health, this can come from numerous other partners that we can offer to rural Georgia. We can provide specialty consultation through telemedicine, telehealth to every county in the state of Georgia. But we're not doing it. We're doing it in a few. It's impressive where it's happening. But that's a gap we got to fill. I was just talking to Dr. Sumner because one of the things that I see as an opportunity for public health when the next commissioner comes aboard in about 16 months, and who's counting, we'll have a new governor, we'll have new commissioners, and I'll sit back and I'll pass on something to the new commissioner. And one of the things I want to pass on is what I consider an acceleration phase that will happen next in public health. The next growth phase that I see for public health is developing an academic health department for Georgia. Now, you may say, well, what does that really mean? What I want to see is a close alignment between public health and all of our academic facilities throughout the state. I think it's a twofold win. I think that we can develop more credibility in public health by having that academic tightness, but I also think that academics can gain by spending some time in the field at the grassroots level. I see a merging of workforces here. And I think this will be a tremendous development for the state when that happens. It'll be cost saving, but at the same time it will be a growth. I think the possibilities there are monumental. And over the next 16 months, we are trying to craft a plan that I'll pass on to the next commissioner that will show what the gains may be. And I hope we'll have MOUs and MOAs in place for the next commissioner between public health, the department, and those academic facilities that want to work with us side by side. This is just a description of what we have right now. I don't know that any of this is terribly important to you. The message is telemedicine, telehealth is out there. We have the capability. We're not using it to the max. We need to. We want to add on academics as part of our consultants. And I think we can provide health care at a level that we've not seen in rural Georgia in the past. These are some of the projects that are underway or have been underway. And many of you may be familiar if you come from counties where you've seen these, and you're going to hear more about them as the day finishes up. But I think that the ability to provide high-level care through increased technology has become so apparent to me that not to do so is criminal. I watch as Dr. Greg Felzine is an infectious disease specialist who oversees our HIV Ryan White program. And he is kind of a tough nut. He's very demanding on what he expects in levels of care. He works with primary care folks across the state of Georgia, nurse practitioners, PAs, physicians, who are now caring for HIV patients. And years ago, that didn't happen. When I was an emergency physician, I saw a patient and first time diagnosed HIV, I certainly didn't start treatment. I didn't send that person to primary care. I sent that person to an infectious disease specialist because the feeling was only those ID docs could adequately treat as complex a disease as HIV. Well, years ago, that was true because they had all sorts of complications that the average primary care person might not be able to handle. But we identify these cases earlier now, and primary care can treat them. But very often, primary care needs a consult. And that's what Dr. Felzine provides across the entire state of Georgia from his office at 2 Peachtree. And then he spends about, 8 weeks out of the year going to every one of those clinics to look at the records, to audit those records, to be sure that those patients are getting the top quality care that he demands. That's just one example of what can happen. Another example that's been really impressive to me was a combined program between Emory and Georgia Power. And in that program, Dr. Rob Harshman, who is the medical director for Georgia Power, was aware that out in the field, Georgia Power folks were very often exposed to sun. So there was going to be a higher incidence of malignant melanoma. So he worked with the dermatology department at Emory through telemedicine. They would go and they would look at a skin lesion, and the dermatologist would make a decision, yea or nay, this needs to be biopsied. This went on for over a year. The numbers of cases that were identified early and have been treated is monumental. In the private sector, so this is not limited to the public sector. The values are just astounding. Just some more of the activities. Again, I'm not going to go through each of those. These are all the different partners that are involved in telemedicine. And I want to emphasize how critical partnership is. Public health will never be able to handle all the issues that face our population in the state of Georgia. But with effective partners, those collaborations can make a huge difference. We can leverage for success by these partnerships. But to think that public health or that funding of public health is going to solve all the problems is not right. We have to build these partnerships. And through these partnerships, we can all make a big difference. Community partnerships are absolutely critical. We had a summit last week in Macon talking about all the partnerships that are out there. And the list is just innumerable. But in all health departments, you will see partnerships, particularly with local hospitals, local practitioners, particularly primary care practitioners, including OBGYNs and pediatricians. That's absolutely 100% across the board in all public health departments in Georgia. In most, there are also critical relationships and partnerships with the educational community. I think it should be 100%. I think we have a responsibility, and education has a responsibility for us to work together. That's where our kids are. That's the growth of Georgia. That's the success or failure of Georgia. So I think those partnerships are critical. But in addition to those, I'm impressed now that we have a system of 14 regional coordinating hospitals in the state of Georgia that we created through the Hospital Preparedness Program. And I was a naysayer back in 2002 when the request came about to set this up. I said, no, it'll never work. Hospitals are too competitive. They won't collaborate and cooperate. Thank goodness I was wrong. Those regional coordinating hospitals have worked together. We saw it in Matthew. We're going to see it again in Irma. Those hospitals protect each other, respond for each other whenever there's a crisis and a disaster. And it's beautiful to watch. Every one of the RCHs is surrounded by 10 to 20 satellite hospitals. When resources in their area are expended, they reach out to Georgia Hospital Association for another area to come to their aid. It works beautifully. It worked tremendously well when we had to evacuate hospitals in response to Matthew, and it looks like we're going to have to do it again probably within the next week. And I'm confident because of the system that it will work again. That's part of emergency preparedness. The partnerships there are with law enforcement, with critical infrastructure, with education, with elected officials. You name it, the partnerships are already there. And it's that strength and robust in a community where there are multiple partnerships that we will succeed. We don't have it everywhere in the state, but we've got prime exemplars in certain parts of the state that needs to be replicated everywhere. Just some examples of partnerships that are in place at the community level that I think really need to be spread elsewhere. So how about sustaining these activities in rural Georgia? I've emphasized the things that I think that we can do in public health, that we are doing in public health, that we should be able to do in every county in the state, but are not doing it to the degree that it needs to be done. And with what we achieve through the enterprise system modernization and the ability to gather data more effectively, accurate data so that we can target our activities where the needs are, I think we can make these corrections. And we can make this sustainable in our state of Georgia. And once again, I'd like to thank the legislators who have, in the past, come up with the funding to help us develop this system, because I see it as the way to drive forward. I want to thank you, but I also want to summarize in closing that we have 3 priorities since Dr. Brenda Fitzgerald left as commissioner and went on to CDC. Brenda accomplished some amazing things in her 6 years here. And my job is to see that the good things that she put into place are sustainable. As Jim Collins, who writes on management, did the Good to Great series, and that was Brenda's prime thing. She wanted us to move from good to great. And I would like to be optimistic and say we've already gone from great to greater. But we're now in a different phase. This is called the built to last phase for the next 16 months. Those good things I want to see are institutionalized in public health in Georgia so that they will persist and continue to improve. But in addition to building those things that we want to keep, I want to give the next commissioner these ideas of some accelerations that can take place as soon as the next commissioner comes in. And the academic health department is the most important of those that we've identified so far. We have 3 priorities that need to be emphasized over and over again. First priority is early brain development. Now, what does that have to do with anything we talked about in rural Georgia? It has a heck of a lot to do. The data is compelling that when we do improve our early brain development in babies from in utero, at least up through age 2, we make tremendous changes in ultimate outcomes in terms of how well those kids do in school. By 3rd grade, those kids that have had the benefit of that early learning, talk to me baby type stuff that sounds so simplistic but is so important, those kids no longer are learning to read, they're reading to learn. And the graduation rates go up to in the mid to high 80% range from high school, as compared to those that don't have it, where it's in the 30s to 40% range. Now, why is that important? Because when they graduate, they can become productive members of society. And if they don't graduate, we continue to replicate our problems with poverty, with mental health issues, with homelessness, with housing issues, even with nutrition issues, where we face diabetes, hypertension, because people don't know how to properly take their food. Early brain development changes so much of that. It's so simple. So that's our key priority, focusing on that. Our second priority, and you can say, what does this have to do with rural Georgia? It's dealing with the opioid epidemic. You better believe it impacts rural Georgia. And we in public health have got to put together with all of our partners the overall strategy for Georgia to attack this. Not just to acknowledge it, we've got to correct it. If we don't, it can destroy our state. And the third priority that the legislature gave us is development of a cardiac care network, very much like the trauma system. And this too can save lives in strange ways. One of which, in rural Georgia, we have got, not just in rural Georgia, but particularly in rural Georgia, we've got issues with infant mortality and maternal mortality that are astronomical. We are 48th in the nation worst for maternal mortality. There is no excuse for this. And you know what's leading, or not quite leading, but almost leading the cause of those deaths of new mothers now? Cardiomegaly, with cardiomyopathy, with failure that's not being identified, but happens usually 3 to 4 weeks after delivery. With a really good cardiac system, we should be able to stop that. So once again, 3 priorities to take away. 1, early brain development, critical. 2, deal with the opioid outbreak. 3, develop the cardiac system for the state of Georgia. Public health is charged with overseeing that, but public health doesn't do it. It takes all of our partnerships to do it. So I want to thank you again. I would ask you to continue to work with us when you have the opportunity. Every single person in here can be a partner with public health. We welcome that. Thanks again.
Questions? You got to go back to the mic, Doctor. Clay?
I am thankful, and every single county has got a health department. Some counties don't have ambulance service, but every county has a health department. And you mentioned 2 or 3 times that there's telehealth equipment in each of these counties, but it is underutilized. But I failed to catch why it's underutilized. Do we not have a doc on the other end for the telepsychiatry? There's no psychiatrist in the rural parts of the state, and there's just none. Is it because there's no doc on that end? There's a need on one end, and there's no doc on the other end, or is it okay?
Just the reverse.
Okay.
The greatest problem is that we do not have the folks on the public health end that are in a position, either time-wise or skill-wise, to be able to communicate with where the consult's going to come from. We've had a tremendous offering of consultations by specialists. That has not been the problem. But in some of those health departments, those county health departments, you may have one nurse who's doing everything. So to be able to stop from immunizing the kids, or the women's health clinic, or from some environmental issue that she's having to call for help on, and actually go to the equipment and arrange the appointment, because you have to have the patient there at the time that you do it. The problem is on our side for the most part. Now, in the health departments where we have large staff, works beautifully. But in those rural counties where we may have 1, 2, or 3, usually one clinical person and a couple of clerical people, in those county health departments, they simply do not have the time. And in many instances, if you're not doing it regularly, you lose the expertise of how to use the equipment. So it can be both an issue of time as well as lack of skill in being able to do it.
So staffing. Okay. Thank you.
Thank you, Dr. O'Neill, for your presentation this morning. Can you help me answer questions for constituents, particular who are working in my area? We don't have access to healthcare providers. There's not a doctor in my home county. Father whose child needed to have their shots, child in elementary school, goes to the local health department, but the local health department tells the father they are not able to provide that service because the father have health insurance. So how do I answer his question of why he was turned away for not being able to get his child's shots because he had health insurance?
You either have him call me or you call me with the information, and we can change that, because that's unacceptable.
Okay.
Turning a patient away, whether it's because they don't have coverage or they do have coverage, is not anything that we in public health can do in good conscience. If individuals have coverage and the health department doesn't have the ability to bill that coverage, and as I say, with the enterprise system modernization, that will change statewide. We will ultimately have that ability, but right now, quite a few of the health departments do not have the ability to bill anything other than Medicaid. But that is not an acceptable reason for turning the patient away.
Okay. All right. Thank you.
Dr. O'Neill, you mentioned this is kind of a 3-part question, so I hope I can ask it. Hope I'm successful at asking it. So in your slides, you talked about the different insurances and payers that you had that accepted your services and you could get paid for them by. And so my question kind of is, what are, for a layman like me, what are some of the activities that you do get paid for in public health? That if I went to your public health facility, what's some things that I could get done that you're going to get paid for by you?
I think probably the largest group are preventive services that we offer. Certainly Medicaid and most of the carriers. And the slide that showed you the large number of carriers doesn't mean that every health department has the ability to get paid by each of those. It means that each of those has some contractual relationship with a public health department in the state of Georgia. Ultimately, we want that relationship to be for the entire department, not for an individual health department. So right now, there are a lot of health departments that only can bill Medicaid, for example, and preventive services are almost always covered.
Okay. Second part, a lot of our discussion yesterday was on lack of access, and a lot of that centered around not having primary care physicians in our communities, and we're losing primary care physicians. It was mentioned by several people yesterday, do you think it would be possible to bring more primary care physicians into public health to handle some of these problems that several have mentioned already today?
I do. I think that certainly we have underway with several of the medical schools here in Georgia right now relationships such that public health is becoming a part of their training program. And the ultimate hope is that some of those physicians will come into public health, but I think it may be even more advantageous if we don't think about bringing physicians into public health, but think about having the physicians, period, to cover certain communities. And I think public health can work with the private sector, not just to encourage them to think about coming into public health, but think about primary care in general and how it can best be provided, certainly with public health as a partner. But I don't think that it's a good idea to think that we need to create a public health that becomes a national health system. I think that's not a good way to go. I think we need to be thinking about what do we in public health, working with the healthcare community, need to do to assure that we have more primary care available across the entire spectrum. And I think public health can have a role in that, but I'm a little bit uncomfortable with the idea of thinking that the answer is to get more physicians into public health. Yes, we do need more, but my gosh, we need more physicians in a lot of different places. And I think from my perspective, it would be more important to work on getting a primary care physician in the community than to getting that person into public health.
Thank you.
I want to follow up on Representative Perkle's question dealing with the telehealth or telemedicine portion of it in rural clinics. It seems to me that in those rural areas that are underserved anyway, that in order to get people access to quality health care that they may have to do through telehealth, that those would be the offices that we would want to enable rather than saying, yeah, it's available in the urban areas because we got plenty of staff. We don't have much staff in the rural areas, but we don't have many doctors either, and we don't have many hospitals, and we don't have a lot of other things. So it seems like that should be the place that we're overstaffed in public health rather than understaffed. What are we going to do to change that?
I think, once again, what we need to do is to be able to have the data to demonstrate exactly where the issues are and then do our staffing based on that data. And right now, our collection of data is so sporadic, so inaccurate, in my opinion, that it makes me very uncomfortable making hard decisions of placing staff based on hearsay. We've got to have strong data to support where we put the staff, and we've also got to figure out how do we grow the staff to go there, and does it need to be necessarily a public health staff that's doing this? I think you probably heard yesterday a presentation by Chad Black on community paramedicine, mobile integrated healthcare. I think an expansion of the role of paramedics into the field, into the homes, where the actual telemedicine may take place from the home, not from coming into the public health office, may be a more effective way to go. I also think that I proposed to Medicaid that we look at the possibility of creating community health workers where public health would have the role of establishing the criteria for each level. And depending upon what the level was, some of it might totally be non-clinical. Just going into a home to see that the individual who may have been a Medicare patient recently released from the hospital but had a regimen that was prescribed, to go in and see that their needs were being met. It might also be a clinical person going in to assist with the delivery of medications to that patient. There could be, I think, at least 4 different levels that I would like to see us develop curricula for, training for, and then have a different structure of reimbursement through Medicaid, through the other carriers eventually, of what we would call community health workers, level 1, 2, 3, and 4. I think that that could offer a tremendous opportunity where you don't have clinical people, but you have clinical needs within a community, where the clinical community health worker would rotate through that area on a regular basis, but in most instances, perhaps much of that could be supported by the non-clinical worker. I think utilizing various personnel for delivery is what we've got to look at. I don't think that overnight we're going to be able to snap our fingers and create the number of physicians that we think we need. So I think we have to look at other short-term solutions, and my view is that community health workers may be one thing that we should be looking at seriously.
Sharon.
Dr. O'Neill, you know, the public health is a area that's very near and dear to my heart. Although 3 months of it in nursing school cured me. I don't want to do public health nursing. In the mountains of Tennessee. What I want to know is, one of the things that the people from Habersham yesterday said is that when they started their program, they were seeing some people, but it was only when they recognized that they should be open after hours that they really saw a great intake. And I'm hearing all over the state that people drive by our public health departments and there are no cars there at all times of days because they work 8 to 5, 9 to 5. And that's not, what's being done to maybe expand our hours, you know, let people have the flexible hours? That's one question. And then, I guess I have 3. I mean, some of the nurses have quit doing nursing. I mean, we have infant mortality. A lot of mothers just flat don't know how to take care of babies. And you talk about development, they don't know why you should read. And we used to do mother-baby courses. It sounds so simple, but in the evening when people could attend a mother-baby course to learn how to take an infant, to learn how hot it gets in a hot car, you know, when you're educated, you think people know that, but they don't. Mothers don't, and especially in some of our areas. And the other thing, it sounds great to say that we're going to get insurance companies to cover it. Well, the doctors are telling us that they have to hire extra people because every insurance company has a different kind of form to fill out, and it's very complicated to see if they're covered. So if we're already short in doing health care, how are we going to overcome that if it's so complicated to collect? It seems like, you know, we need to go after the money, but we're going to have a problem. So there you go, 3 questions.
And I think
Sorry.
No, your questions are absolutely on target. And I think that the answers are not on target, unfortunately.
Okay.
I think that we are not doing an adequate job right now of identifying in every part of the state where the after-hour needs are. And following this meeting, I've got a televised VIX meeting with each of the district health directors in Georgia, and that's one of the topics that we're going to be discussing, is what do we do to survey and find out what are the hours that the public in that particular area really needs coverage at the clinic. The sad thing, though, is that the coverage is almost needed, I wouldn't say 24/7, but probably 16 hours out of the day. And the workforce is not adequate for that. We can shift the hours, but we're going to slight somebody in the process of doing it. But I think that we can, if we get good data on what the requests are, we can do a better job. So that's going to be my request of all the district health directors. I want a survey from every district of patients in that area that are coming to the health department and what their preference would be for when that clinic needs to be open to be able to serve.
But that could be skewed, Dr. O'Neill, by the fact that if the services have not ever been available in the evening, there's lots of people out there that won't be surveyed that would say, oh, yes, I would be there after work when there's only one car in the family and I have to go to work or my family goes hungry. And so I hope you only take that as one part of that.
Once again, I think you're totally on target as always.
I'll come work with you, but not out in the field. There we go.
I think that that's also where the partnership piece comes into play. We need to be talking to the elected officials in that community who know what their constituency is. That constituency is probably talking to them, maybe more so than they're talking to public health. So we need to be talking within that partnership. We also have a coalition, every one of our regional coordinating hospitals, which covers the entire state of Georgia, multidisciplinary coalitions of 80 to 90 members. We now have over 900 members statewide. Those coalitions need to be giving us feedback as to what they're hearing from all of their various constituents. This is multidisciplinary. So those coalitions can be really valuable in giving us a broad sweep of what the desires are of public health in that community. We need to be listening more. We're only using them right now in disaster situations. That's crazy. We should be using them for all types of health issues. I think that also the comments that you made about insurance are absolutely on target. My hope is that when we do have the enterprise system modernization and we have the billing and claiming and billing section, that we will have specialists at the state level that will be able to do a better job on the billing for the entire state, not leave it up to the individual health department to figure out how to bill
How to
Aetna.
do it. Okay.
So that's part of our plan. Again, even when that's in place, the movement, the changes in what they pay and what they don't pay is just astronomically difficult to follow. And you're never, ever going to be able to collect all that you really should be eligible to collect with that movement occurring.
Okay, thank you, Chairman. I wanted to ask you, you had a couple questions about telehealth in these centers, and you said that there's the access is there in every county. What I'm interested in knowing is the same equipment available in every one of these centers, and what level of diagnosis can they do with these? If they can, I mean, I can understand what you're saying about, I mean, it would be problematic, I would imagine, to go through the process of finding somebody at another end someplace to work with that. But what level, if they can get somebody, what level of diagnosis or, what can they do through that equipment? And then I do want to know also, first, is the same level available in every one of those 159 counties?
No.
I'll answer your last question first. No, the same level is not available.
Okay.
Again, it depends upon the skill of the individual who is using the device to transmit to the specialist to give a consult. And that skill level varies from one county to another.
Right, but I'm
And
not
again,
interested in the skill. I mean, what I'm talking about is the actual equipment that's been used. I'm sorry if I
the
didn't mean to
equipment's the
interrupt,
same. The equipment's the same. But the ability to use that equipment with the outcomes that you want is not the same.
Right.
That's problematic. Now, there are examples of all sorts of things that, and I've gone on too long and I don't want to belabor this, but there are many, many things that can be done with telemedicine. Teledentistry, for example, is wonderful in the school setting, and utilizing the hygienist to basically do the evaluation and shoot the images to a dentist to say, yes, this kid needs to come in and see a dentist, or no, all you need to do is this, this, and this, and the kid can go home. That's of tremendous value. And if you talk to educators, one of the primary reasons that kids are absent from school is because of toothache. So our ability to deal with that is really critical. Also, it's impressive, again, I talked a little bit about the high maternal mortality rate in Georgia that's so unacceptable. With telemedicine, we can actually do colposcopy. We can transmit a picture to an OBGYN specialist, maternal fetal medicine specialist, who can give advice on a lot of these high-risk women that will say, all you have to do is this is not to worry about, or we've got a major problem here, we need to transfer this patient within the next 12 hours or we're going to lose this baby, whatever the situation might be. So utilizing it for that, for the so-called centering pregnancy programs is also important. We can basically do prenatal care with a group utilizing telemedicine to the maternal fetal medicine specialist and cut down tremendously on early term deliveries. And why is that so important? Well, if you look at the data between a 37-weeker and a 39-weeker on average, the 39-weekers have considerably higher CRCT scores in school. Sounds crazy, but it makes a huge difference in early brain development. So there are a whole host of things that we can do to benefit pregnant women using telemedicine. I mentioned also identifying a terrible malignancy, malignant melanoma of the skin. Easy to do with the dermatologist looking at it through telemedicine. Pediatricians can benefit tremendously looking at a kid's ear with a questionable finding that it may be that the public health nurse is not sure of, simply putting in the otoscope, transmitting that picture, and the pediatrician saying, oh yeah, we need to do this or that. So there are a whole host of uses for it, many of which I could spend probably another 30 minutes talking about each individual ones and bore you to death. Sure.
Dr. O'Neill.
Thank you.
All right, now we're going to hear from Dave Flanders, who's the CEO of Candler County Hospital. Chairman England has told me that he gave me the mic this morning. I promptly got us 30 minutes behind. So I'm going to ask everybody to sort of, let's get to the point, get what we want. We want to get to the meat of the matter. And so let's hear from Dave Flanders.
Good morning, Mr. Chairman and fellow members of the council, and thank you for allowing me to come talk this morning. Thank you for including Metter as one of the cities on your tour of rural communities. Can you hear me now? It's really encouraging to see the amount of energy and effort that's being put into identifying problems with the rural hospitals in the state, and we are very appreciative of your efforts. Yesterday, we heard some very informative briefings and very informative presentations from the teaching centers and from GHA, and they were very high-level presentations. And today, I want to try to talk on a little different level. I want to try to give you a different viewpoint from an environment where we routinely operate on a 3 to 5 days cash on hand environment, and give you a boots on the ground type of an idea of what it's like in a rural hospital in Georgia right now. What's working, what's not working, and some recommendations that we think are important. First, I'll give you a little info on Candler County Hospital. Who are we? Well, we're a 25-bed critical access community hospital. We're county owned. We are hospital authority governed, and we're managed by a management company, ERH Healthcare. What do we do? Well, we do a wide variety of services, including inpatient, outpatient, ICU, emergency services, and primary care to the citizens of Candler County. We specialize in swing bed rehabilitation care for patients that need physical, occupational, and speech therapy to get back on their feet from post-surgical at another facility or post-surgical treatment at another hospital in another part of the state. We provide strong outpatient surgical programs that feature gastroenterology, vascular, and general surgery. It gives our patients a safe, professional, and economical option to have their surgical procedures done close to home. Why do we do it? Well, patients in the rural areas deserve good quality health care without having to travel extended distances to a larger hospital in another county. We save lives daily in the emergency room by treating conditions like heart attack and stroke. We stabilize critical patients and then utilize telemedicine to talk to other physicians at bigger facilities in Augusta and Savannah and arrange transport to a higher level of care. We offer clinics that provide primary care for the citizens of our county. I think I skipped it too. There we go. Challenges. Well, challenges are many, as I'm sure you all know. One of our biggest challenges, the $1.6 million in indigent and charity care that we provided in 2016. While the Indigent Care Trust Fund provides a good bit of relief on that front. It's still $1.2 million short of covering all those expenses. For a hospital our size, that's a tough pill to swallow. Candler County's total population of 11,000, low median income, and a payer mix of only 9% commercial, sizable percentage of Medicare and Medicaid, and 13% self-pay, puts a heavy burden on Candler County Hospital to collect on self-pay accounts and leads to a large bad debt write-off. In 2016, we wrote off $4.7 million in uncollectible bad debt. Thank you, Damien. So that is another really hard hit for a hospital our size to take. Legacy debt. Many rural hospitals are dealing with legacy debt. Ours is largely attributed to expenses from the implementation of an electronic medical record, trying to meet meaningful use requirements required by the federal government, that failed to provide a working financial module. We couldn't, for over a year, Candler County Hospital had a terrible time with collections, with billing, and at the end of that year, they wound up removing that system and having to purchase a new system. The losses during that time totaled $4 million. A lot of that $4 million is still sitting there. A lot of it is in AP now that we continue to struggle with. As a critical access rural hospital, we can get to a point where we break even operationally, and we're still not able to handle and go back and touch that old debt that still plagues us. The aging facility and equipment, like somebody mentioned yesterday, many of our hospitals were built in the 50s and 60s, and ours is no different. We have aging chillers and aging boilers that are original equipment from the 60s that would be very expensive to replace, so we keep nursing those along. And it does affect our ability to give patient care. Things like nurse call systems, telemetry systems, refrigeration systems are all obsolete and are difficult to get parts for now. Payer contracts are a major problem for us, and it's I'm sure with all with all rural hospitals around the state. We have identified through work we've done on contract negotiations that we're getting paid ridiculously low contract amounts by the big payers. For instance, Blue Cross and Blue Shield, at one point, they were paying Candler County Hospital less than we got for Medicaid patients. So we were able to go back in and do some negotiations and get that raised, but that continues to be an issue with all the payers. We just don't have the bargaining power as an individual hospital to go back and negotiate those, but we do as a group, and I'll touch on that a little bit later. Provider recruitment. We've heard that over and over in the past couple of days. We struggle with that as well. We have one full-time doctor that lives in Candler County. We have some other coverage from other primary care coverage that come from Statesboro and do 1 to 2 days a week in the city of Metter. But we still have struggled heartily with trying to get a physician to come to Metter and buy in for a long-term commitment here. Recruiting services are very expensive and have been ineffective in even bringing in a physician that are looking to make a long-term commitment. Another look at our payer mix. I mean, it's obvious where the problem is. If you look at the national average payer mix, and you see when you look at self-pay, a 3% national average and a 13% in Candler County. 24% of our residents are uninsured. So it is it's a constant struggle to collect those self-pay accounts. I got ahead of myself a little bit. Competition. We have a lot of competition in this area. We are surrounded by other facilities. And we talked about our aging infrastructure. 3 of our major competitors are in facilities that are much newer, much better funded, much better shaped than ours are. So it's a challenge for us to be able to convince our patients that we can do the care that they need. But we have our information shows that the quality of care at our hospital and all rural hospitals is as good or better than the care at the larger surrounding hospitals. We can confidently say for the scope of services that we provide, there's no reason to leave home for medical care. Some of our closest competitors have newer and updated facilities, and that attracts physicians, nurses, and patients. We have to be able to prove that we can give the same quality of care. Collaborations. Our biggest collaboration is within our own group. We have, in the ERH family, we have collaborations with Dormany Medical Center, Emmanuel Medical Center, and Irwin County Hospital in Ocilla. We actively work with all of our member hospitals to share services. We share senior leadership across all 4 hospitals. The geographically close hospitals, we share a lot more actual boots on the ground sharing of services. We, with Candler County and Emmanuel Medical Center, share a CFO, a business and billing office, a quality manager, lab manager, infection prevention, nurse educator, central scheduling, pre-certification department, and all 4 facilities benefit from group purchasing power, medical and legal expertise, clinic operations managers, and contract negotiation team. Non-duplication of services is important in a group of collaborating neighboring hospitals. At CCH, we refer patients to our sister hospital in Swainsboro for geriatric psych and for overflow, and they refer to our gastroenterologist and swing bed program. East Georgia Regional in Statesboro is a major competitor, but recently we have opened the door for collaboration with them. The majority of our swing bed customers and patients come from doctors at East Georgia Regional Medical Center. They come to CCH for post-operative rehab, freeing up a bed at East Georgia Regional for new surgery patients. In return for this collaboration, we send transfers to East Georgia Regional from our ER when they require a higher level of care. Collaboration with the Candler County government has been crucial to the hospital's survival. The county implemented a parcel fee in support of the hospital, and we currently get a one mil tax support for our operations. This continued support is crucial, and it's vital for the hospital to continue operations. The tenacity of the hospital authority has been another collaboration that has been crucial for us. We have the 7-member authority. Their tireless efforts to communicate and collaborate with the county and to help us coordinate with the county for county support has allowed CCH to persevere. CCH is a member of the Archway Partnership with Candler County and UGA. The University of Georgia has provided resources to assist with our community health needs assessment and many other items in strategic planning. We surveyed the county and are using the results of this survey when making strategic decisions for how our health care will be delivered in the future for the next several years in Candler County. Now, the next slide, I need to quantify. I need to remind the members of the council about the letter that we got and with the information request that you wanted us to be blunt and straightforward, and so we are. In the next slide, we talk about failures. And I want to quantify that in the fact that I don't consider any effort that we do from the state level, government level, hospital level, anywhere, anything that we do, any program that we start, I don't consider any of those a failure. I think some of the things you'll see on the next slide are programs that just need a little more work. The biggest one, first one, is we still don't have a viable long-term solution for insufficient Medicaid reimbursement. The current reimbursement rate of 20% of charges is already extremely low, but it really means 20% of allowable charges. And the allowable charges are getting more and more restrictive. So think about the 20% of charges. It's very tough to operate with that margin. The Senate Bill 258, the Rural Health Tax Credit, has been a great help to CCH, but it's a very indirect attempt to resolve the core problem of poor reimbursement. The 3-year program will help and has helped but it needs to be 100% credit to get max participation. Indigent and charity care costs continue to rise, and the Indigent Care Trust Fund reimburses about 25% of that expense overall. Ideas for restructuring rural hospitals have not produced a workable solution. Rural hospitals are actively looking for ways to be more efficient and to find that perfect blend of services that we can provide and those that need to go to a higher level of care. The freestanding emergency room idea will only work with a total and complete overhaul of the current reimbursement system. The emergency room, without the other hospital services to support it, is unsustainable. UPL payments are coming in later each year. They used to arrive in May or June, but as of 2017, as of this year, we had not received it till September, at this time in September. Provider tax, and I'm speaking, this is not so much for us at Candler County Hospital from a critical access point, but this is some of our other sister hospitals that pay the provider tax. It needs to cover at least the cost. It's very hard for small hospitals to come up with the payments for the provider tax, and the rate adjustment needs to at least cover the cost. I'll go to a little more pleasant subject. Successes. The Georgia Heart, or the Georgia Rural Tax Program. In Candler County, we're sitting at about $235,000 in pledges so far. We have been very successful. We could hope to continue being successful with the program. It has allowed us to purchase new surgical equipment for our gastroenterologist, to renovate our ER triage area, to renovate outpatient physical therapy. And the next phase of the tax credit program will bring some much needed renovations to our patient care, patient room areas that haven't been upgraded since, in some cases, the 70s or the 80s. The physician assistant and nurse practitioner loan repayment programs have been very well received, and that allows $10,000 for student loan repayment for nurse practitioners and PAs, and that has been a huge help in our area. Again, not necessarily for us, but for some other hospitals that still have OB departments. They are benefiting greatly from the newborn OB add-on payments that started at $250 and now have climbed to $500. That's a major help to some of our group hospitals. Rural hospital stabilization grants have also been very helpful. $250,000 for grantees for new services or care coordination. I got ahead of myself again. One of our CCH, the next slide covers our CCH successes, our individual successes. We have, as part of our management team and our contract negotiation team, we were able to renegotiate our contract with Blue Cross and Blue Shield this year. The contract renegotiation team negotiated a deal that came up with a rate that leads to a positive impact on our bottom line of about $750,000 in a year. Now, to Blue Cross and Blue Shield, that's a very minor impact, but to Candler County Hospital, that's a very large impact. That's a huge annual impact. Before these efforts, Blue Cross paid us lower than Medicaid. In the last 2 years, we've been able to purchase several new pieces of radiology equipment by utilizing the CCH Foundation, which has been very successful in raising money. And we purchased a mammography unit and an ultrasound unit. We also have purchased a C-arm for use with vascular surgery. We have produced 45% in mammography studies, an increase in mammography studies annually by use of the new equipment. The ultrasound is brand new, but we expect a substantial or a similar increase in the utilization of that piece of equipment as the providers realize the better care. Our swing bed rehabilitation program is known around the area as one of the best. We recently added a full-time doctor of physical therapy, PhD, to run our rehabilitation program. The swing bed program has proven to be our niche in the overall healthcare landscape in this area. I think it's important that as a critical access hospital that we find that niche, that we can find some service that we can provide over and above or at a better rate than the PPS hospitals or the larger hospitals around us. as a critical access hospital, we get reimbursed at a higher rate for swing beds than our neighboring PPS hospitals. And I hear, just yesterday, I heard that that rate is increasing again. So that's a very important niche for us. It provides a way for the bigger hospitals to clear beds and open beds for new patients, and it provides income for the rural hospitals and gives us, with our robust physical therapy program, it gives us a very good foothold in the community. We have had some success in attracting part-time physicians from Statesboro. The medical staff in the Statesboro area is strong. They have lots of physicians. They have lots of volume in that area. And we have gotten some interest from some of those doctors in coming over to Metter and doing some side work in Metter. It's not the perfect solution, but having a physician in the area 1 day a week or 2 days a week is preferable to the situation we had just a year ago when we were faced with the possibility of not having any doctors. So for a while we were down to just nurse practitioners and PAs, and that model works well, but there are just some patients are just not going to be happy with that situation and are going to go elsewhere. And with the situation we have with competition all around within 20, 25 miles, patients will leave if we're not able to attract physicians. Recommendations. Our recommendations are things that we think are very important. Preservation of the Indigent Care Trust Fund. I can't say enough about how important that is. We're hearing that there's a chance that it may be cut even more. Right now it covers about 25% of our indigent care. So we would think that not only preservation of it, but an increase in that fund would be beneficial to all the rural hospitals. Medicaid bonuses for nonprofit rural hospitals that meet predetermined standards for quality and provide urgent care as an option to the ER. We heard some folks talk about that yesterday. I think Medicaid is tough. We have a large Medicaid population. If the payments were increased based on quality, based on the services that we provide, that would help rural hospitals a lot, and that would that would really solidify our payment base if we can get Medicaid to where it needs to be. We need to change the rural hospital tax credit to 100%. The GOLD program with the private schools is fully utilized and reaches the cap quickly every year. And I believe that the hospital tax credit would have that level of participation at 100% quickly. And that program has proven to be a valuable asset to us. And I think that's a low-hanging fruit that would be easy to implement and would help at least in the 3-year term that the rural health tax credit is already slotted for. At least in that 3-year term would be a viable program for the hospitals. We need to incentivize larger rural hospitals to collaborate with rural hospitals. The larger regional hospitals need to be encouraged to facilitate networks where rural and large hospitals work together to identify and implement productive niche programs. We talked a little bit about our niche program being swing bed. I think at some point we need to figure out a way to incentivize the larger hospitals to collaborate. Right now, they don't have that. Right now, we can offer services, but financially it doesn't always make sense, and they're not always eager to give patients to us. They're not always eager to let us have a crack at their patients that might not come back to them. So hospitals are still a little territorial, even though we have made great strides in the past year or so in collaboration with many of the different hospitals. And the last but certainly not least thing I have is protect the CON. The condition of need has to be protected. We have to save the services that generate revenue for us and for all the rural hospitals to allow the CON to open up and to allow ambulatory surgery centers and things and clinics of that nature would really hurt rural hospitals. Thank you, and we're open for any questions you have.
We've got, we're going to be hearing from Bacon County Hospital in a little while.
Okay.
So if we could hold off on questions till after we hear from them, and then there might be questions generated from
Okay.
that presentation that you might be able to answer and contribute to as well.
Okay.
Thank you
Sure
very
will.
much.
Sure, thank you.
Next, we have Charles Owens, Clinical Associate Professor at Georgia Southern University. And welcome, Dr. Owens.
Thank you. I appreciate the invitation to come and talk to y'all today. It's was a great honor to be able to come and share with you some of the great work that those of us at Georgia Southern have worked on over the years. Just to give you a little bit of background of me, I've worked in rural healthcare, born and raised in rural, and so when you ask me this question, it's really hits close to home, and that's one thing that I think is very important. As we work to strengthen our rural economies, we've got to look for rural solutions. We can't think that other people are necessarily going to solve our problems. So we've been strengthening rural communities since 1906. Obviously, Georgia Southern at Statesboro was a very rural community way back then. And that's what we were founded on. And so this is just a short list of our colleges, just to give you a background of what we look like. We've got about 20,674 in student population right now. What's interesting to me about that is about 20% of that population is rural. And it doesn't sound like a lot when you look at the 20% number. We wanted it to be significantly more. But when you drill that down and you compare it to our state population, it's very representative of what the state of Georgia looks like. I'm very proud to say that 92.4% of our students are also Georgia residents. And I'm sure you've heard and know that we're in the process of consolidating with Armstrong University. And so when we accomplish that task over the next year, we'll then reach 27,000 population. What's interesting then, when you look at Southeast Georgia, we'll be positioned, of course, in Bullock County, Chatham, and also in Liberty. Currently, we're in Bullock and Liberty, so we'll be glad to add Chatham into our family of schools. So I currently serve in the Jinping Tsu College of Public Health. And so when I hear Dr. O'Neill talk about an academic medical center, it really goes hand in hand with how we practice, and we look forward to working with them to do that. We have talked about it over the years, so seeing it come hopefully within the next 16 months is very exciting. So what do we do in the Jinping Tsu College of Public Health, specifically in support of rural communities? There's several different things. We, of course, focus on evaluation and assessment and technical assistance. Those are our core blocks of services that we provide, and we do that across the continuum of care. We've done extensive work with public health, helping them move through and work to receive national accreditation. We have helped them with community and state and regional level assessments and evaluations so that they have that data that Dr. O'Neill talked so much about, and helping them to work through challenges that we find in those data sets. We worked with 18 rural communities to accomplish community health needs assessments, which was a requirement of the Affordable Care Act. We're now into the third wave of that. We just got our first request to help a hospital for the third time on their needs assessment that we've been working on over the years, so that's exciting. Lastly is the Rural Hospital Engagement Needs Assessment. And that one is a little bit different. We received a grant where we could work with 4 communities to, again, talk about need. I know you've heard that word an awful lot. But to also talk to community people about their level of engagement with the hospitals. You know, one of the challenges that rural providers face across the continuum, when you're in a rural community, and those of you that live there, you know it, you know everything. And that can be a good thing and a bad thing. It's great when you're trying to network and get things accomplished. It's not so great when you're trying to overcome a stigma or overcome an image issue. So it was exciting to be able to work on that project. Lean certification has been embraced across industry as the standard. We've seen a lot of our urban hospitals to embrace it and move forward with it and have been very successful. And so we're working on a grant with the Department of Community Health, State Office of Rural Health, to bring that to some of our critical access hospitals. We just had a training the other day. Cindy Turner was at that, where we were working with them to get it kicked off on those steps to achieve a green belt. So knowing that we can bring some efficiencies and process improvements to them is very encouraging. For the last 2 years, I in particular have worked with the State EMS Association to look at EMS, because in particular when we talk about EMS in rural communities, it requires tax dollar subsidies because it's not financially sustainable on its own. So we've spent 2 years talking with EMS professionals about how do they work, what are their strengths, what are their weaknesses, what can we do to help build upon that. You know, there's lots of talk. I understand you had a presentation on mobile integrated healthcare, or community paramedicine, as some states call it. We know that so many of our patients that we see in our hospital, that we transport by our ambulances, that have special needs, don't require a lot of highly skilled services, all right? They require that hands-on personal attention, and that's one thing that that program can bring to us. So we're excited about that. We created a financial model where we could give a tool back to EMS services to take this spreadsheet, plug in your numbers, play with your revenue, play with your expenses, and help them adjust their budget so that they could find one that they could live with and manage. The last bullet talks about technical assistance, testing and monitoring in rural communities related to things like lead, bacteria, mosquitoes, things that cause negative health outcomes. We consistently across our college we require our students to have practicums, research projects. We make sure that our students are going back into the communities, and we call that service learning. And so that's going to come really to fruition in full force once we develop an academic public health department. So that's important. And when you see that, when you look across the university, you'll find that same basic element, because it's a core philosophy from our president down, to make sure that our students go back. We want to train, to educate, but we also want them to take those skills and know how to apply them when they come back. I was really excited. It was a pleasant surprise when I walked in the school building this morning. I hope some of you saw that the school here is a Georgia Southern partner, which means, and I have that in a slide a little bit later, but we partner with them to help the teachers make sure they're meeting the needs of their children, that they have the latest, greatest education things that we can bring to them. I want to talk to you now about the School of Nursing. We're ranked 10th as one of the most affordable online nursing programs. We have a nursing program from RN all the way through advanced practice nurse. We have a partnership with the Georgia Partnership for Telehealth. We're trying to train our nurses so that using telemedicine is common. They're comfortable. Dr. O'Neill talked about the challenges that you have when you don't use a skill a lot. So we want to start in the university setting where we're teaching them to use telemedicine where they expect to use it. What's interesting is this generation coming through expects telemedicine. They want to see, a provider on a phone. A few months ago, I caught a bug and I was at home and all of a sudden felt sick and whatever. So I called my doctor, who, fortunate enough, I have his cell number, so I called him. But I know when he's busy. So he wait, and I wait to get some drugs, all right? What was unfortunate, Blue Cross reminds me, use telemedicine. The light bulb didn't go off in my head. That's one of the biggest challenges we had. Somebody asked that question, what's the challenge with delivering telemedicine? You've got to make me, the patient, think, this is my option. I can do this. Let me call, let me connect. And then how can I do it? Do I do it through a school setting? Because eventually we want to move that from just a teaching environment to where we actually have a clinic environment so that patients, either students or people perhaps from off campus, can come in and receive care. And again, it's back to that hands-on training and treatment. They received a $1.6 million HRSA grant for advanced practice RNs to develop those nurse practitioners to go back to work in rural and underserved communities. Jenny Wren is sitting somewhere back over here in the room, and she's a partner in this, and we were excited to see her in the press release and that she's engaged in this, because Jenny has 10 sites scattered around East Georgia, all right? Just like when they were talking about recruitment of providers, I'm sure she will attest that recruitment is a challenge. So she's going to help us with training, but what we want to give her back in exchange for that is an employable, well-educated student that can meet my needs. I personally see a nurse practitioner. All right, I'm 50 years old. All right, once I got out of childhood, I haven't needed a specialist, knock on wood. All right, a nurse practitioner can meet my daily needs. And so we need to make sure that they're scattered across our state to serve our folks. Christ Community Health Services in Augusta, J.C. Lewis Primary Healthcare in Savannah, Curtis V. Cooper in Savannah, and Appling Healthcare down in Baxley. So 2 of our centers that are at the table with us are rural, and the other 2 are in poor areas of our urban markets. The Center for Gerontology, you might not have thought you were going to hear from them today, but what was interesting when I got to talking to them, I did a blast email to find out what all we've done, because I've only been at Georgia Southern for a couple of years, so I knew there was lots of work that I wasn't familiar with. Discovered this great program. They're working in 9 rural counties. They've got 37 low-income adults, basically lay health workers, who are going in and visiting with 129 older adults or people with disabilities. They're doing this on a budget of $238,000. What that money goes for is a little bit for administration, but the bulk of that money goes back to the low-income residents. It gives them a source of income. They get a nominal amount of money to go in, to check, and to follow up with those 129 patients. And that's not a huge number. However, it doesn't have to be a huge number to help, in particular, clinics or rural hospitals, because sometimes it's the small number of people that consume the greatest resources that also take out the biggest chunks out of the Medicaid budget. So when I saw this, I was incredibly excited about that. And you'll see some of these counties are incredibly rural. Bryan, Candler, Evans, Jenkins, Screven, Tatnall, those are really rural. And sometimes it's hard for people to get from point A to point B. So they also oftentimes get gas cards so they can then transport the patient from point A to point B. How great would it be if we actually got telemedicine in that community, and perhaps in the public health department, and we know there's some resource. Now if we can get this low-income adult volunteer connected with public health, and we can start to get that care bridged. Writing and linguistics, that's part of the sign out front. We're a partner with our school system in various counties, Tatnall, Evans, and Bullock, because we want to make sure kids can write well. All right. How many times have we hired an individual and we interviewed them and they were awesome, but then they wrote something? All right. And in the university setting and in my past life at the Department of Community Health, we wrote all the time. And when we're communicating back and forth, it must be articulated well. And one thing I quickly learned, regardless of educational level, writing skills weren't that great. All right. And so we've got to get back to the basics. And so seeing that we're working in these 3 communities to make sure our K through 12 students are coming out with strong writing skills is important, because when they get to me, I teach a healthcare finance course, and they don't think they're going to have to write in there. It's a pet peeve of mine, so they write. It's because you've got to be able to explain your financials. You've got to explain what you have figured out. Why are you not getting adequate reimbursement? How are you articulating that in writing? So raising that quality of standard for that is critical. Psychology, someone referenced the lack of psychologists across the state, or access to mental health services. That's one of the greatest shortcomings we have in our state. So we have a new program, it's about 4 years old, where we're producing master's level counselors and psychologists, all right? We have 4 practicing in Bullock and Effingham counties, but they run a clinic when they do this training, as a lot of clinical training does. So they see patients in a low-cost environment there in Bullock County. The College of Liberal Arts. Now this I thought was interesting, because I told you it's in my philosophy that rural folks are going to have to come up with some rural solutions so that we strengthen ourselves. Here's 2 perfect examples. Over in the communications department, Robert Todd worked to develop a film to produce or to share information on McIntosh County's shrimping industry. Why would he do that? Because he's from there. His family, he's a 4th generation shrimper. we have another person, Jennifer Sweeney Stokes, and she worked on a marketing project to expand opportunities for Georgia's seafood and coastal commodities. Why did she do that? She's from there. Her family roots are there. That's important to her. It's important to Joseph. And so was incredibly excited to see that we're doing work in that area, because, you know, I'm from rural Georgia, grew up on a hay farm. Aquaculture or shrimping doesn't kind of get in my realm. I love it. You know, it's great to go to the coast and see it and be a part of it, but we don't think about it. Some of us that have historically been more inland don't think about it. So part of the question that I was asked to come and talk to you about is what works and what should we or could we do to help rural communities be better. I think we've got about 4 to 5 building blocks that we need to work on. And those are education, health and healthcare access, workforce, industry, and business, and a tax base. If you lack those, and I'm sure you can name a dozen communities right off the top of your head that by far does not have these things in place, all right? You know, so how do we get there? We need to figure out how we're going to strengthen each one of these pillars in each community, because they're there, they have different weaknesses and different strengths. So we need to have broad-based community planning. This means not siloed like we normally do it. One of the biggest areas of frustration, you've heard me say needs assessment a dozen times today that we work on these. And one of the most frustrating things is we get a phone call and they say, hey, I need you to do a needs assessment for my hospital. Well, guess what? Your patients are also part of the federally qualified health centers, all right? They're also part of public health department. We also eventually, sometimes if we're lucky, we get a call from those people and they want a needs assessment. Well, all right, well, we've just done one in your community. So, but what we need to do is do a community health needs assessment for the community, all right? And the community is defined by those people at the table, all right? It's not by city lines, county lines, district lines, all right? Because guess what? In my community, those lines are defined by me. I was talking with Dr. O'Neill earlier today, and I said, you know, my healthcare system, my network, is defined by me. It's not the public health district that I happen to live in, all right? I go to the referral hospital that I want to see. I go to the local hospital that I want to see. I see the specialist because I have transportation and can do that. And in large part, even people of poverty make those same choices. So, all right. So how do we lay the foundation? Again, we triage, just like you would a patient that walks in a medical practice, all right? Triage the patient, all right? What's wrong? What needs to be fixed? And we do it at this level, region, county, and community. Why is that important? Because they feed one another. Rank and organize based on the assets, all right? Rank, do the same based on needs. Identify the access and the unique resources. All right. Identify critical deficiencies. All right. There's been lots of PR about poor school outcomes. It's a huge deficiency. We've got to figure out how do we improve that. Hopefully our partner schools with Georgia Southern aren't on that list. But if they are, we need to know it, and we need to work to move them off that list. And then establish priorities for development. Who does that? The community does that. The people at the table. We can help facilitate it, but the community makes that decision. All right. We just spent a full day, which was not nearly long enough, but it was a start in Dodge County, which is a little further east of here. All right. They invited us to come, and they said, how can you help us? And we got the invitation. Wasn't well thought out at all. I had a graduate assistant at the time. He graduated. He actually wound up getting a job at the chamber. And the chamber started figuring out, well, that's a pretty nifty stuff you learned over there. So come and start. So we started networking, all right? And so with that, it's kind of grown. What they really asked us to do was to help them figure out how to develop more workforce. Dodge County is kind of unique. They're in the top 4%. There may be more Dodge County folks here that I don't recognize right off. So if I speak wrong, stop me. But they're a really unique community because of their aircraft opportunities in that community. They have an airport. They've got the aviation school. And so they've attracted aircraft industries there. All right? You don't expect to find that in a rural community like Dodge County. All right? They have huge contracts from all over the country and even the world. And so how they're concerned about how they're going to meet that need. And they have spec buildings that need to be filled. So if they fill those spec buildings with 24,000 population, there's not enough people to go to work. So they're starting to think about, from a regional workforce planning, how do we move that forward? So it's a very exciting, and they're really looking at this because we met and we talked with them at school. What are your challenges in school, K through 12? Because we need to not only produce graduates from Georgia Southern, we also need to produce graduates from the technical college. Because when you look at those industries, those folks are across that spectrum. So doing community and regional planning with the individual community people having the ownership, that's critical. We're not going to come in and tell you how to do it. Long-term commitments in relationship. You know, assuming this partnership with Dodge County continues to mature, we should be there 10 years, 15 years even. All right, whoever comes behind me should still go back to Dodge County. All right, so that we keep growing, because they could continue to morph, especially if we continue to grow their local economy. So I put my phone up here where I could watch the clock and didn't do it at all. So I hope I stayed within the time limit, because I was trying to be sensitive to getting you out of here on time today. So
We're going to ask you to hang around. We're going to have questions before the break. And so let's give him a warm thanks. Next, we have Cindy Turner from Bacon County Hospital. Cindy?
I brought some help. I have my chief operating officer, and he's also director of pharmacy at our hospital, and we appreciate being asked to speak at this meeting and give you some information that we recently received at a meeting that we were at, and we're going to give credit to the physician that presented this. But all right, how are we clicking? Okay. But this is a picture of the hospital in McRae that closed in 2008. And just think about how you would feel if this was the ER in your town, if you were having a heart attack, if you'd gotten bitten by a snake, or if you had had a farming accident. And that's why we have a passion for rural hospitals and keeping them open.
Since 2005, you've got a list here of some hospitals that have closed, and the more recent trend is to see later dates, 12, 13. From our hospital in Alma, we can drive to some of these places very easily and very quickly. It's heartbreaking to see it.
You can see from this slide that 60% of the closures are happening in the southeast. And from here you can see that most of those closures are happening in a state that did not expand Medicaid. And most of the closures are 50 beds and under. There's a few that's over 50 beds.
So why did they close? The news media put together some little slides, and that we'll give credit in just a minute to the man who made this, but small and declining populations. Poverty is the biggest. High unemployment rates across the state, running as high as 18% in different niches. The Georgia Department of Labor doesn't report numbers quite that high. You'll see 5.1 seasonally adjusted. Competition, one of the other speakers talked about here in Metter how close other larger facilities are, but I go back to that very first picture. What if you're the farmer here in this county that was bitten, school-age kid here needed to get to an ER? We'll talk about physician coverage in just a second. Debt.
Other rural hospitals have more volume that drives their revenue. And even if you're critical access, you have to have volume to survive. That being critical access is not the magic bullet. And you can see here the bold line shows you what break even is and how many hospitals are not even breaking even in Georgia after all of their deductions have been taken out. Unemployment and poverty, as Kyle said, are two of the leading causes in rural communities. It's why hospitals are not breaking even. While most of them are, you can see about 50% are losing money because of indigent and charity care and our indigent care being cut that we get every year, and our upper payment limit being cut. This slide is talking about the age of plant. At Bacon County Hospital, we started a building program, and we get no county funds from the local property taxes, but the county has over the years given us some SPLOST monies for to renovate our hospital and bring it up to date. And we started a huge building project in 2008, and we built a whole new inpatient unit, a second story onto the hospital. And after we got through with that, I looked at the numbers before and the numbers after. I've been there 36 years. I started when I was 5 years old. So but most of that time I was there, I was the CFO. I've been the CEO for 12 years. So I like numbers, and I looked to see if our volume, if after we upgraded the facility, we got all new equipment, if that made a difference, and it did. We had a 20% increase in patients coming to our hospital after that. You can see here average FTE. This is for Georgia. It's not because we're overpaying our staff. So how can we deliver care at less cost per day than the other rural hospitals? We're small, and many of us in our facility, we wear many hats, and we talk to each other all the time, so we can get together and have a little huddle and make something happen like that. Where at a big hospital, I've dealt with some larger hospitals. It takes weeks and months to get something to happen as far as change, because it has to go through all these committees and everything, but we don't have all that. We just get a group together, and if we need to change something, whether it be something with our quality program or something with our budget, then we get together and we make it happen. You can see here the hospitals that are just in financial distress. 16.6% of them are in the South. This slide just gives you a percentage of hospitals at risk for closure. In Georgia, we're 50%. In the United States, it's only 24%. I'm not going to go through this slide. The only bullet point I want to explain is the third one down, and that the reason why that's the way it is our charges are much lower than many of the other rural hospitals that's not critical access. So our cost to charge ratio is higher than those hospitals. This is some more bullet points that just recap what we've said. And we're one of 2 critical access hospitals in the state of Georgia that still delivers babies.
This is a summary slide. Dr. George Pink made this presentation this past August at the Georgia Hospital Association's Rural Health Meeting. That data that you'd seen up to this point. This slide comes to us from Merritt Hawkins, a recruiting company, and one of their previous presenters talked about how expensive it is. Guys, there's headhunters to help us find doctors, but you can make your salary on what it costs to get those in here. The shortage can go up to what we're expecting, 43,000 primary care physicians coming. It's big. A suggestion, increase medical school capacity for in-state residents. We got some really fine medical schools in Georgia. Who's in demand? There's the top 20. family practice, internal medicine, obstetrics, peds, ortho, and general surgery all made that top 20 list, and that's what we need out in our areas. This is a nice slide to show you how long it takes to recruit somebody. A lot of talk on psychiatry in here, and that takes the longest. Peds on that list was at 8.7 months. We just landed a pediatrician in Alma. She'll be starting with us at 1st of January. It took me a solid year to get her to come and vet her. Salaries, I know those are big numbers, but guys, Atlanta pays that. So if we're gonna get them to come to our areas, we've gotta stay competitive with the salary markets. So what else can we offer? How about some tax incentives or income tax breaks to these physicians to come? We gotta put something on the table, because they can go around and make this money anywhere. Simple law of supply and demand.
Mid-levels, we do use mid-levels in our community, but there's limitations that's put on them, and we feel like that if we can expand their scope of practice, that we would be able to utilize them more.
My training, I'm a 20-year hospital pharmacist, and I'd never heard of the word centralized credentialing until I made my role as an operations officer. But when we get a physician, it took me a year to find my pediatrician. It's going to take me 120 days to get all of her T's crossed and I's dotted to be able to send my first bill out to anybody. So one of the recommendations would be, let's get us a statewide consortium here of somewhere to help speed this process along. Commercial insurances are actually worse than Medicaid and Medicare.
Every insurance company requires a different form.
I can speak to this one. Drug shortages not only affected rural health, but health across the nation. Guys, we couldn't get salt water in our hospitals. Incredible. We spent $128 a case for 12. A case has 12 bags of fluid in it, where we normally spend about 18 bucks. Diprovan, that's the Michael Jackson drug. We couldn't get it into our operating room, so we had to cancel surgeries. Zosyn, a very powerful IV antibiotic, I had to change other antibiotic selections around. Solumedrol short, Protonic short. So what does that mean to legislators? It means that these are medications you're not going to find at Walgreens and CVS and at your local corner drugstore. People in our world, hospital pharmacy, are affected by this. Georgia Board of Pharmacy did not have a hospital pharmacist representing us during the bulk of this time period. So I challenge you, don't let that happen again. Keep one of us on that Board of Pharmacy so that we can help troubleshoot, brainstorm, and come up with ideas to prevent these big shortages in our hospital settings.
This is a slide that I like to use. This is the hospitals in the middle, and all these people around us are the people that are regulating health care, whether it be the state government, the federal government. We are the only other industry in the country that's more regulated than healthcare is the nuclear plants. And it's hard in a small hospital to cover all of this stuff. Like I said, many of us wear many hats and we divide these duties up. But the first time I showed this to our governing board, they were taken back.
Information technology, it's not the wave of the future, it's today. Any of you that owns your own private business, you're familiar with this one. It's expensive to bring in a new system. EMU means meaningful use. That's the standard put out by the federal government, that if you meet some of their information requirements, they'll give you a little money. Well, their money's run out, and we're still left holding the bill to pay for all of this technology. To get interfaces, this is at Bacon County, 25-bed hospital system. Look at all the different interfaces that we've got running there. We spend $650,000 a year at Bacon County Hospital and Health System just to maintain these information systems right here.
And that's not included, that doesn't include the salaries that we pay 5 IT people. That's just what we pay to the companies for software support.
So one of our suggestions or a talking point is, again, a regional consortium. Why does Bacon County have to reinvent the wheel when Candler's already done it, Irwin County Hospital's done it, Coffey's done it? can we get together and create some type of firewall, cybersecurity, data exchange amongst ourselves to reduce cost? And I know we're not the only hospitals in here, so guys, let's think about this. That word's already come up probably 3 or 4 times already this morning. It's big. I'm a pharmacist. One of the drugs that's used to treat stroke is Activase, or tissue plasminogen activator. Great drug. If it's started timely, we can save heart, muscle, and brain, and people can live, even out here in the boondocks. But that drug itself can kill you. So without the appropriate person on the other end of that camera helping our people in our ER make that definitive diagnosis, a hemorrhagic stroke means you're bleeding. Well, you don't want to give a drug that's going to cause a bleed because they'll die on you in the ER. There's real value in having that camera set up with a neurologist that we can't put out in the rural areas, set up in our ER as well. Public Health mentioned this, the universities mentioned it, but we use them in our ERs too. And here's 2 success stories at Bacon County.
I can tell you, I happened to be in the ER one day when a 40-year-old lady came in with a stroke. And we got the neurosurgeon on the other end of the telemedicine equipment, and he said to administer TPA, and it was amazing how all of the drooping and everything that she had straightened up in just a matter of minutes after that drug was administered. And it saved her from being disabled the rest of her life. Okay, on this slide, as you can see, I'm very passionate about community hospitals. I believe we're the lifeblood to our communities. The only other entity to me that's more important is our school system. And I was born in my hospital, and I've lived there all my life, so I'm very passionate about Bacon County. But most people don't realize that cuts to Medicaid takes away resources all across the board. It's not just to the Medicaid patients, it's to all of our patients. And when we receive cuts, whether it be state or federal, we have to sit down and we have to decide if we're going to cut a service that's a low volume service. We have to decide if we're going to lay off staff. And it just all rolls downhill, so to speak. And meantime, patients that can't pay, that are indigent due to the EMTALA law, they can come to the ER and get free care all day long. And that affects everybody across the board. And used to, we could pass those costs off to the commercial insurance company, but a few years ago, they kind of caught on to that. And as the County Dave said, they're ratcheting down what they're paying us as well. But, so I just wanted to put that up there for y'all to think about. The next slide, it shows you the contractors in our hospitals and in our communities. Out of all the contractors that deal with the state or the federal government, healthcare is the only one that's paid less than what it costs them to deliver those services for those individuals. All the other companies, the road architects, engineers, the folks that build roads, they're paid their costs plus a little bit of a profit. And the hospitals are the only ones that's not paid even our cost. We just wanted y'all to see our pretty hospital. I drive by it all the time and I say, boy, everyone who works at that hospital must be really smart to have such a pretty hospital. We have a great team and we've been very blessed.
We prepared a summary sheet too, so you didn't have to write notes while we're talking. I think we gave it to, Ethan's got it in the back.
Ethan's got it.
We'll pass it out.
Very much.
Okay. Dave, would you like to join us for questions? Do you want us to do questions now?
I want you to stay up there, and I want Dave Flanders and Charles Owens to come up and join y'all. Butch.
Unfortunately, it takes several weeks and even months to get your providers, like your doctors that you've hired, credentialed. And until they are credentialed, you can't bill for any services they provide,
Right.
I think.
You're
But-
providing free service all that time.
But when they become credentialed, will the insurance companies and all allow you to go back and retroactively
No.
do that? How
The only
long?
one that goes retroactive back is Medicare, and Medicaid does go back to the date. We always send those certified to the date that they signed that they got the certified application.
We've heard some other people talk about this same problem. How long would you say that it takes to get someone completely credentialed if they're a clean provider? By that, I mean they have no problems or anything like that. What would you say would be a sort of an average time for that to happen?
What we're experiencing right now is about 120 days. I mean, we've got 2 doctors that we just signed, a general surgeon and a pediatrician, and we gave them a start date of January 1st because we know it's going to take us that long to get all our provider numbers.
And if they provide services before that credentialing happens, you're just out of luck as far as being
The
able to
hospital
bill.
doesn't get paid and the physician doesn't get paid.
Thank you.
It's crazy.
Yes, sir.
You, and it was also on the Bacon County side, you said y'all wrote off 4.6 million in bad debt. Is that indigent or is that just bad debt?
That's bad debt.
Just for the council members, I want to reiterate the
It's a
fact that there
combination of
is
everything.
a piece of legislation in Ways and Means that will help soften the bad debt, and it's specifically designed for rural hospitals, just on bad debt. Huh? Ain't nobody holding it up, it's just in Ways and Means, and there was some arguments. I just want to get all the ducks in a row to get the help, to run it right on through so the author don't have to argue with the chairman too much.
Well, that's encouraging. Thank you.
Obviously, I wanted to make a comment to the committee while some of our leaders from Bacon County are here. But you'll hear 3 words as we travel around this state time and time and time again. You're going to hear community, you're going to hear collaborate, and you're going to hear leadership. And you heard Miss Cindy mention that she was born in that hospital. And we have talked a lot about trying to incentivize young men and women that are talented and are intelligent to be able to go off and get college educations, particularly in the area of healthcare, to go back to these rural communities. And I just wanted to say that in Bacon County, the most unique strength that I think they have is most all of their leadership was born and raised right there in and around that community. From Ms. Cindy to Kyle to Kevin Ellis that's sitting over here on the side for economic development. And when you get people that are born and raised in these communities and you get them a good education, you get them trained and you can bring them back, that's where collaboration happens. Because they were raised in that community together. They already know what the other one's thinking before they even meet in the room. You go to most of these counties and the folks that are running these hospitals, nothing against them, but they aren't deeply immersed into the roots and the culture of that community and understand how to collaborate. They have the education, but putting that education to use is a whole different thing. And to see them come back and be the leaders in Alma and Bacon County and the success that they've had. So what I hope this committee will do is see how important taking those young men and women, the talent and the intellect of those communities, getting them a good education. It's not going to cost them $300,000 when they are getting to go back home and be able to pay those loans back. But Cindy, just to ask you a question to follow up, how important, because she does a wonderful job at this, how important would you say it is that these community leaders interact on a daily, weekly, and yearly basis with their legislators, not just at a meeting like this?
It's extremely important because if you don't have a relationship, I have a good relationship with Representative LaRicky as well as Mr. Butch here. And if you're not letting them know what your problems are, then nothing's ever going to get done about it. So you have to be able to pick up the phone, know them. When they're in our community, we try to support any events that they're doing. We invite them to the hospital. We're proud to show off what we have. We also have an 88-bed nursing home, and we're rebuilding it right now. And I invite any of y'all to come down and look at our facilities. One thing that we started in the 1980s, I've been there since 1981, is a program, a loan program, where we do give loans to people from our community that have the desire and the grades to go on and make a physician. And return, they have to come back and practice so many years in our community, and we've been successful with that. But we also got physicians at the annual workforce recruitment fair that y'all used to fund for rural hospitals. So that's one of the things on our suggestion list to bring back.
Just a couple financial questions for Mr. Flanders. You referenced, first of all, an increase in the Medicaid reimbursement. And I keep having problems with the question that I hear so much about Medicaid expansion. Why would you want to expand if your reimbursement isn't high enough?
That's a good question, and that is a constant battle for that balance, because
Is the reimbursement more important than the expansion?
I think so. I think if we could get reimbursed better for what we do, that would make more impact.
And then secondly, and this confused me just from a legislative, you referenced the hospital provider fee.
Right. Right. That wasn't for our critical access hospital. That was for some of our other
All right, that's where I wanted to get in the weeds a little bit now, because as a rural legislator, I know the benefit of that
Right.
is the fact that we're drawing down and you have winners and losers,
True.
okay? And we draw that Medicaid fee down to help you. Doesn't your hospital actually benefit from that particular fee here locally?
I would think so, yes. But
Then I was confused.
Yeah.
That's what
Well,
caused my confusion, because
the fees that we have to pay in are not necessarily covered by the rate adjustments, so it's a loss.
but the hospital tax that you referenced, that you said we.
Provider tax.
Yeah, you called it the provider tax. Okay, yeah.
Yeah.
Well, yeah, but,
Med tax.
yes.
Right.
People that are elected call them fees. Yeah. Not that there's a political disconnect on your part. But seriously, when we look at that and we study that, some of the bigger hospitals that don't do the percentage say that's almost them paying to help you.
True.
So I would expect you to be an advocate to continue that, not to abolish it. So I didn't know if you were speaking from a Candler perspective when you showed that slide.
Not from a Candler's perspective, because the critical access hospitals don't participate in that.
Yeah.
Yeah.
Okay, so it's a good thing?
Can I say something?
Yes, ma'am.
GHA, since Carrie Summers came on board, she has worked very hard to make that to where everybody breaks even. There's still some losers. I mean, and Ethan, you might can speak to that. There's still some losers, but they are the larger hospitals, not
But
a
the
lot
rural
of-
hospitals, we did that thinking we're actually helping is our point.
Mm-hmm.
And we were told we did.
And I think some of the ones in our group are having a hard time funding the payments, and then they feel like the resulting rate adjustment is not covering that amount. I could dig more into that and get you some more information on that.
Well, Ethan will be able to address that. I mean, we're told that actually benefits rural hospitals more likely than not.
I think it probably does.
Okay.
On a case-to-case basis, it may not, but overall, we do support those.
But everybody can't be winners.
Everybody can't be winners, and what we're seeing as an industry, we're not breaking even.
Okay.
And I think this year it's gonna be somewhere in the range of $60 million loss.
I was just surprised to hear a rural hospital. I thought it was helping you. Thank you, Mr. Chairman.
But it's affecting our rural hospitals?
I think mostly for our rural hospitals, again, generally speaking, our rural hospitals are gonna benefit from it. But, the original concept, when it was first passed, I think in 2010, was for the industry to break even. So whatever the industry paid in after the drawdown, and it was kind of shared throughout the Medicaid program with physicians and other healthcare providers, was that hospitals would get back overall what they paid in.
I just don't want to
That
vote
is-
for something we're
there's a
told
great
that
disparity
helps
right
rural
now.
hospitals and then it doesn't help rural hospitals.
Right.
Yeah, no, I think generally speaking, it
Okay.
is of benefit to the rural
I mean,
hospitals.
I'm more concerned about the rural hospitals than I am about my big hospital that's buying everything up and paying cash for a new hospital and advertising at hundreds of thousands of dollars, I'm more concerned that they might not get as much back as I am the people that run these rural hospitals.
Again, generally speaking, it is a benefit to the hospital. And we do, as the association, we did support his recommendation.
We have a couple more questions. This is for Candler and Bacon. The information systems, technology, and all of the different platforms that you have to do, you said that you thought that it might be helpful if you could collaborate with other hospitals so that everybody doesn't have to reinvent the wheel and invest in this kind of technology. What can we do to make that possible?
Support a local consortium. University. Regional.
Yeah,
You've got
regional.
Georgia Southern here that's presented many different avenues that they've got their hands in. They also have a very strong IT department, training people, getting ready for the world of informatics. So my suggestion would be, can we pair up the smaller hospitals, and Charles, I'm gonna give you a plug here, because I got 2 undergraduates. Those guys are bright. We've got a good platform already in place. Now it's just a matter of working out the details. How can we pull hospitals together with universities and education systems to help us build firewalls, to help us plan? We've got the next phase of meaningful use coming up.
They do this in Idaho. Is Idaho right, or Iowa? It's one of the Iowa. They do this. All of their small rural hospitals is a member of a consortium, and they have the IT system hosted for the hospitals. So I don't have to employ 5 IT people and pay all these software fees. Maybe it could help decrease some of that. I don't know how many IT people you employ, Dave.
Well, we share 4 across 2 hospitals.
About Iowa, so that maybe we can help get something done on that. Robert Dickey has a question.
Thank you, Mr. Chairman. I want to get back to this indigent care or lack of payment. It's just so different. I'm just learning about this hospital model collection, and so many going out of business because your cash flow's not there. I mean, are we at a point where payment for health care is just optional? Y'all just serve everybody that comes and just cross your fingers and hope we get paid, and those hospitals in poverty areas are just not going to get the payment, and those in other areas are? I mean, is it just totally optional now to pay for health care?
Well, it's not optional. We still go through the motion, and we still do the collections and the billing, and we try to collect those.
Well, do you restrict delivery of the health care to people who cannot pay? I mean, how do you
No, sir.
build that model in?
You can demand payment up front for non-emergent type situations, and we do try to do a lot of upfront collections, try to get
Right.
at least part of it up front. But when somebody comes to the ER, you really can't do that. You have to see them.
I understand that.
Federal
but-
regulation.
It's a federal EMTALA law, so we have to see them.
Yeah, I mean, I'm very compassionate and expect that, but it's just, it seems like in rural areas, poverty areas, this lack of payment is a huge portion of your cost.
It is.
I mean, or lack of cost.
And we have a lot of programs in place that try to get people qualified for Medicaid. We try to get them admitted to any program that they might be available for, that they might qualify for. So we try to go through the steps to make sure they're not strictly self-pay. If we can find some program that will fit them, we try to get them enrolled.
But it's also an economic development problem. We don't have the industry that Atlanta has, or some of the bigger cities have, Savannah.
Right.
We don't have the industry, and I know years ago we used to have what was called a Heart of Georgia tour, where they would come to the rural communities and look at our hospitals and look at our community, and we did get some businesses like that, but I'm not sure that that's still going on now. I haven't participated in it lately.
We're going to take a break, and if y'all will just sort of hang around for a while, because we got some other folks that want to ask y'all some questions. Chairman Ingram.
Just going back to the provider fee for just a second. Now, as I've always understood this from the day that we started, there have to be winners and losers, or else the federal government does not allow for the state to participate. So if a hospital is providing at least 11.88% Medicaid or greater services, then they can participate, or they become a winner. The further they get into that, the deeper they get into that percentage, the more they benefit from it. If they fall below that 11.88%, the closer to zero, the higher they pay. So I just want to clarify that there have to be winners and losers in order for us to participate at all, period. And our cutoff right now is 11.89 or 11.9%. So if you're at 11.9%, you're basically going to get in what you pay back. But if you go to 12, you're going to get a little more than you pay back. If you're at 11.5, you're going to get a little less than you paid in. But it was, you know, as we sat there and chewed on that to do it to begin with, our understanding was that there are institutions in the state that provide less Medicaid coverage and indigent care than others do, and it was kind of a partnership, so to speak, of one helping the other. So just want to, not so much a question, just a clarification comment.
Mr. Chairman, just a point of clarification about that. Just the term winners and losers, I think can be a little inaccurate, because if you're a winner, that just means you're getting back a little more than you paid in. If you're a loser, I just think that's kind of piling on, because at the end of the day, everybody who participates in the Medicaid program, all the hospitals lose money. We get paid about 85% costs, not charges, 85% of costs. So you add on almost 12% of that, you're still losing. So the winners still lose in the Medicaid program for every patient they see. The losers, we prefer to call them net positive.
Just like putting nickels in a slot machine.
That's right. And just one final point of clarification to Chairman Reiner's question about why you would want to add more people to those Medicaid rolls. Right now, we're talking about the uninsured population. We get paid zero for those. Maybe 10% of the cost if you are able to collect anything. So do you want to add them to the Medicaid rolls where you're losing money on Medicaid? Well, 85% of costs is a lot better than 0% of costs. So yeah, we do want to find a solution to the uninsured population. That's right. We may not necessarily call it Medicaid expansion. We want to find Georgia's solution, something that is sustainable for the state, is sustainable for the providers, and certainly gets the patients the care they need.
We were going to take a 10-minute break, but now thanks to Ethan, we're going to take an 8-minute break. And be back in your All right, break time's over. Let's get started.
So you want me to tell Chris Clark to cancel his meeting?
All right, Clay. All right, let's get started. Everybody take a seat. Well, thank you. All right, next we have Monty Veazey, who is the president of the Georgia Alliance of Community Hospitals. Let's give Monty a welcome.
Saw her running around, and I look around, and there's several chairs, and leaders. So thank you, committee members, for taking time out of your schedules to be here today to listen to us come to you in Poor Mouth. Before I start, if you don't mind, I would like to show a short video that we recently put together. This is a doctor over in Clay County, and what she has to say is what she experiences in Clay County, but it's not unique. There are a lot of counties, such as Clay County, in rural Georgia. So if you will, bear a minute.
Several of the others are under a lot of significant pressure, and we hope they'll be able to stay open. Emergency services are a particular problem out here due to the distances. I mean, it's 20 miles to any hospital, but it's 40 or 60 miles to a hospital to really deal with trauma. Getting those patients to the hospital can be a real struggle. For a long time in Clay County, we didn't even have working ambulances. We had a situation where a student had broken their leg last year, and it took 10 hours to get them to pediatric specialists. Things in Clay County are pretty limited. We don't have x-ray machine, we don't have EKG, we don't even get lab work back till the next day. We don't even get lab work back till the next day. So when you walk into a room with a patient, you've got to be able to know how to diagnose a patient without all that technology. Providers who work out in rural counties really need to be more highly trained than people would need to be if they worked in a city where they would have colleagues to ask and a lot of technology to help with the diagnosis. My office is the Clay County Medical Center. It's housed in a former Tastee-Freez. It doesn't look like a medical office should look, and the roof leaks, but it's what we have here. We have one receptionist, one full-time nurse manager, and then several part-time nurses. Basically slightly under 3 people for the practice in addition to myself. People from Clay County as well as from surrounding counties. About 60% are African American, 40% are white. They have a variety of things. Internists are trained to handle most medical problems of adults, but often it comes up that patients need a specialist of some kind, either a heart doctor, kidney doctor, or something that I can't provide here. We have tremendous problems getting those services for patients. The first thing, they're a long distance away. People either don't drive, can't drive, don't have the gasoline, don't have a car in some cases. And furthermore, they often can't afford the cost of the specialist. Obviously, I can't do surgery here or do a CAT scan here. People, if they cannot get those services, really are not getting modern health care. When patients need a specialist, they really need a specialist. I mean, I don't know the things that specialists know. Communication is a real problem out here. Many people do not have internet at their homes. Sometimes they'll go onto the library to use the computer inside. At the clinic here, our internet speed is not fast enough really to run the computer, the medical records correctly, nor to run a telehealth system. We would like to have telehealth. What we would use it for would be for follow-up visits primarily, for patients who've already been to a heart doctor, kidney doctor. You can even use it for pediatric visits. We don't have any pediatric services in the county at this point. We've only been able to keep the clinic open by seeing a variety of patients. About 23% are Medicare, 18% are commercially insured, 10% are Medicaid. That leaves 48% who do not have insurance. We charge them $10 if they can afford it. If they can't, we don't turn anyone away. The only way we've been able to stay open is by seeing everyone, by using what the insured people can pay us so that we can take care of everyone. There needs to be some system where rural health care can be funded. We provide a lot of subsidy to the patients, both by underwriting the cost of their visit, underwriting their labs, and getting them free medicines. If we weren't able to do that, I don't know how patients would be able to get those things for themselves. Patients who have chronic health conditions need to be taken care of. When those conditions aren't taken care of, it becomes very dangerous for the person as well as very expensive for the system. We know rural health and rural health care are a mess. Clay County is not unique. All of rural Georgia has issues with poverty, transportation, and access to good health care. Your health shouldn't be determined by your zip code.
Mr. Chairman, thank you very much. Madam Chair, pleased to be with you. The situation Dr. Kinsel just described sounds something like third world country. Not what you expect in the United States, but Clay County is not unique. 63 counties in Georgia do not have a pediatrician. 78 counties in Georgia have no OBGYN. And I had some slides coming up on that. Okay, we do have some slides that will follow along with my conversation here this morning. Should I just go ahead and continue? Okay. Dr. Kinsel said many Georgians don't receive modern health care because their communities do not have enough population to support the requirements of modern medicine. Generational poverty and lack of economic development are part of the story as well. Today, the distance between a patient and the care they need is a major obstacle. It prevents some patients from receiving routine or preventative care, resulting in them reaching the hospital in far worse shape. Dr. Kinsel identified three major issues preventing patients from having what she calls modern health care. She said three major issues are poverty, transportation, and access. But for our discussion, I'll say major issues are healthcare finance, distance to care, and access to care. Poverty is the big picture view, creates a payer mix insufficient to support services. Transportation in our current system, and this means additional costs for medical transportation when neglected conditions become emergent. From a system perspective, the issue is distribution of services and facilities. Access, which means not just the distance, but also the services that are available there. When a rural doctor doesn't have basics like an X-ray machine or EKG, it imposes additional costs on the patients, prevents many from getting timely care. When the patient gets to the hospital, it's later in the progression of the disease or disorder, complicating care, driving up costs, including costs borne by hospitals and the public. So as I'd like to give a hypothetical to illustrate how these three factors create bad outcomes for patients and a bad financial outcome for the healthcare system. If a patient comes to Dr. Kinsel and needs a specialist, which she has a difficult time getting simply because many do not accept Medicaid or uninsured patients today, it may be weeks before they can put together transportation, financing to get there. Distance and poverty may prevent the patient from getting follow-up care and her or his medications. When the patient's condition gets worse, they end up in a medical crisis, in an ambulance headed toward the nearest hospital, far sicker. The cost to provide follow-up care and help with medications would have been far less than the cost to the hospital receiving a very sick patient who is unable to pay for care. At the emergency room, the hospital has to treat them regardless of whether they pay their bills or not because of federal law called EMTALA. Now, EMTALA is the largest unfunded mandate on you and our hospitals and our doctors. The financial burden of their treatment falls on the hospital. So we have a worse outcome for the patient and a bad financial outcome for the hospital, all because they couldn't get follow-up care and medicines close to their home. Telehealth or telemedicine, if the technology were available in clinics like Dr. Kinsel's, it would provide greater access to specialists, allowing follow-up care. But telehealth requires a robust internet access, which these communities also cannot afford. It also requires some way of reimbursing the specialists who are working remotely on patients in rural Georgia. I want to set the stage for our discussion by defining the issues facing rural Georgia's healthcare system. The first issue is not just about property of the individual patient, it's about the mix of payers in an area with high levels of generational poverty and a series of government decisions shaping healthcare finance. In the hospital industry, we talk about our payer mix, and Dr. Kinsel told you what the payer mix is at Clay County Medical Center. 23% of her patients are Medicare. 10% have Medicaid, which Ethan said we're paid 85% on the dollar a cost, neither of which covers the cost of care. 18% commercially insured with high deductibles, and nearly half have no insurance at all. In 2015 presentation by Dr. Paul Brown of the Medical College of Georgia gives some perspective on how the payer mix varies in regions of Georgia. Poverty in rural Georgia is not just about individual patients, but a structural difference between the economy of Metro Atlanta versus rural Georgia. Because it takes a body of patients to support a doctor's office or a clinic or a hospital, even those who are well off and well insured can lose their access to care because of their regional economy and a bad payer mix. This also affects the willingness of doctors to move to rural areas or specialists to see patients. We must reimburse our doctors more if we expect them to provide care to rural Georgia's needs. The second major obstacle to rural care and rural hospital is distance. When patients are unable to travel to required specialists, they tend to put off their care until it becomes a crisis, leading eventually to a very sick patient in an emergency department. Convenient access to specialists and to preventive care can help lower the overall cost of treating patients. But it's a question of the initial investment and the rate of return, where the returns we're looking for is lower long-term costs for treating diseases. Telehealth has probably the greatest potential to help close the distance separating patients in rural areas and modern health care. But one of the major obstacles to greater provisions of telehealth is the same as the previous problem. Expanding telehealth requires significant resources, especially when broadband internet is not available in large parts of our rural areas. I do want to recognize Speaker Ralston, Lieutenant Governor Cagle, as well as you and many other legislators who are working hard on the issue of expanding broadband access throughout Georgia. The third major challenge for rural hospital is preserving access to care. From the healthcare delivery system perspective, this means preserving the Certificate of Need program. It's the state's only tool for ensuring financial stable healthcare institutions with appropriate facilities, locations to serve Georgia patients. Now, CON has 17 major considerations, but 3 that are dear is, number 1, you must establish there's a need for that project before it's built. You also have to determine, is there an negative adverse impact on an existing facility, and it makes sure there's appropriate distribution of healthcare services across the state, not just in the high zip code areas. We spoke about the importance of the payer mix, the percentage of commercially insured patients versus Medicare, Medicaid, and the uninsured. Certificate of Need gives the state a way of preserving stable payer mixes in existing facilities. A trend we see in metro area and some of the other cities in Georgia is proposed new facilities to treat only well-insured patients and only offer a limited array of lucrative procedures. Removing the well-insured patient from the payer mix of existing hospitals can and will destabilize our existing hospitals. Ambulatory surge centers, they have the ability to not accept uninsured and Medicaid patients, and some of them do not take either, worsening the payer mix of a nearby hospital. Dr. Kinzel would tell you her greatest problem is getting her patients to subspecialists that they will not accept Medicaid or uninsured. And unless we reimburse them at a greater rate, she says they're not going to take them. So we need to be paying our doctors what it costs to provide their services. We cannot expect them to open a tray and lose money. So if we undermine the financial stability of our general hospitals, we could have only facilities treating well-insured patients for lucrative procedures. Losing hospitals because of their payer mix turn unstable will worsen the problem by increasing the distance traveled for care. Certificate of Need is absolutely vital to retaining what remains of our rural hospital system. We were given 3 specific questions to discuss, and I want to turn to those issues, though I may switch it up a little bit. Question 1, with the uncertainty of the current healthcare debate in Washington, what are the best worst-case scenario for rural hospitals? That's a toughie. In Georgia, under Obamacare, we continue to see a very high rate of uninsured patients, people who can afford Obamacare, which, as we mentioned, undermines healthcare finance. We also see patients who have such high deductibles they feel like they can't afford to use their insurance. Fear of high deductibles can leave patients neglecting conditions until they become a crisis, or it can lead to unpaid bills from providers. Now, a new survey we just got back says that we collect 5 cents on the dollar on deductibles. 5 cents on the dollar of deductibles. So overall, the payer mix is deteriorating, even where it was not as bad as it was in rural Georgia. In the hospital industry, the standard is you must make a 6.4% bottom line rate of return in order to maintain your facility, to invest in the new technology, and to upgrade as necessary and be considered to be financially stable in order to comply with your bond covenants. A number of our hospitals are running a negative 3% rate of return or greater. This means they're unable to maintain facilities, equipment, and be able to retain physicians and specialty training needs and have trouble upgrading when it's medically necessary. What we're seeing in any realistic scenario for federal health care reform is that much of the federal Medicaid funding will be converted to block grants. And we're hearing assurances this does not mean cutting Medicaid. And from the perspective of Washington, D.C., they can say that with a straight face. Medicaid will be reduced over time if you go to a block grant, because they're going to look for the state legislators, they're going to look to you to make the cuts where you deem necessary and balance the budget on your back. And some communities in Georgia have already stepped up with additional fundings to their local hospitals. An additional uncertainty as far as the federal government is concerned is the disproportionate hospital payment, what we refer to as DSH. These are federal funds paid to hospitals with higher percentage of patients of Medicaid and uninsured. Under Obamacare, DSH payments were to be phased out on the assumption that all states would expand Medicaid. Decreasing DSH payments was a stick under Obama to force states to expand Medicaid. But Obamacare is still the law of the land because Congress didn't repeal, replace, or reform legislation. There's been some press about the effect of the large DSH hospital recipients like Grady in Atlanta. But the effect on smaller rural hospitals would be devastating unless DSH is reauthorized or replaced in some fashion. Today, nothing suggests that the upcoming federal changes will help rural hospitals in Georgia. In fact, under the Rural Hospital Tax Credit Program, we have a convenient list of rural hospitals in the most difficult financial straits and ranked according to need. An additional challenge facing all Georgia hospitals is the opioid overdoses and the mental health issues. Opioid addiction and mental health issues and related problems are clearly a public threat. But waves of overdoses like those hitting Middle Georgia with 12 patients over one weekend in June and another 8 in one weekend in August threaten not just the individual lives, but important parts of our healthcare system. Beyond the death toll of these overdoses is a massive toll the overdoses and the mental health issues are taking on our EMS, our police, our sheriff's department, and our hospital emergency rooms. The average cost today of treating one single overdose in a hospital ICU is $92,400. Partly this is because we're seeing older and less healthy victims today. The ages of the August overdose patients was 25 to 60. When a 60-year-old patient who may have several chronic conditions overdoses, it's much more complicated and expensive to treat them. Mental health patients who come into the ER departments often stay at the hospital because there are no appropriate facilities to release them to. Every day they spend in the hospital because they can't be discharged to a facility costs that hospital thousands of dollars. The federal response to the opioid crisis has been confusing. And we don't know what the federal resources will be available to law enforcement, to first responders, or to hospitals. We'll move on to the next question we were asked to address. What are the challenges and successes of rural hospitals? What can be done to improve healthcare access in rural Georgia? I think we covered the majority of the challenges to rural hospitals. But I'd like to go back to the 3 factors Dr. Kinsel listed. After all the grim news, I'm pleased to be able to report that Georgia hospitals are having some success in all 3 of these areas. What we hope to see moving forward is an opportunity to work with you, the legislature, and to work together and build upon these successes. From 2014 through this year, 7 counties in Georgia held referendums asking voters whether to levy additional taxes in order to financially support their local hospital, and all but 1 did so. While many of our elected officials oppose raising taxes, when voters were given a choice to support their local hospital, they did it overwhelmingly. While the resort is very fortunate for these hospitals and communities, it might demonstrate that voters understand Washington is not going to rescue their local hospital. Those voters recognize the importance of their hospital to their health, their well-being, and their economic growth of their community that they chose to live in. Telehealth or telemedicine can offer greater access to care and saving to the healthcare finance system. This summer, the Senate Healthcare Reform Task Force visited Tift Regional Hospital in Tifton and heard from some of Georgia's leaders in telehealth. One of Georgia's teaching hospitals told of a pilot program to bring specialist consultation to ICUs in remote hospitals. There's a significant investment to build out telemedicine technologies, but using remote consolidation dramatically improve patient outcomes and reduce Medicare billings and the care thereafter. Other pilot programs would provide care for veterans, stroke care, dermatology, which can deliver better patient access at lower cost. Tift Regional Hospital in Tifton presented the results of their patient-centered medical home model, using improved communications and data analytics to improve routine and preventive care, while ensuring better compliance with medical regimens after acute episodes. Modern communication and data analytics can drive better access to specialty care, better patient outcome, and lower the cost. We hope the legislature, our medical institutions, our public health agencies will consider a significant investment to leverage the efforts already underway in our hospitals. Georgia offers 2 major types of tax exempt. Question 3, what are the current tax exemptions for not-for-profit hospitals, and have they assisted Georgia's rural hospitals, and have they have failed or been manipulated? Now, I don't know any that's been manipulated, but Georgia offers 2 major types of tax exemptions, and we'll discuss them in turn. The Department of Revenue estimates the cost of the hospital sales tax credit to be between $171 million and $189 million per year. To give you a sense of the size of this, the film tax credit cost the state is foregone revenue as follows. In January 16, Governor Deal cited a report by the film and video industry showing the industry is responsible for 79,000 jobs. By comparison, hospitals employ over 145,000 Georgians. We're not criticizing the film tax credit. It is an important part of Georgia's economy, and it's helped create jobs, but the sales tax exemption for hospital is also successful in supporting jobs and the state's economy, and gives the state good value compared to other programs. Hospitals, in many cases, are the largest existing employers in their community, And we're talking about preserving jobs we would lose if the hospital should close. The other major tax exemption nonprofit hospital receives is property taxes. This is sometimes a more sensitive issue, especially at the local level. But there's important limitation on property tax exemption, and that is under the Georgia Code. It only applies to property used for, number one, providing a patient care, two, providing and delivering healthcare services, and three, training and educating physicians, nurses, and other healthcare professionals. So if a hospital buys property it will later build a patient care facility on or for other purposes, it will not be tax exempt from property taxes unless or until it is used for one of those specific purposes. Local governments and hospitals sometimes argue whether a particular parcel or building is being used for tax exempt purposes. Counties have a method of spot checking this, so we have no further recommendations. Earlier, sometimes a dispute over local government taxing or rezoning property tax exemptions. Earlier this year, the Georgia Court of Appeals ruled the Medical Center Hospital Authority in Columbus was entitled to a tax refund for property taxes improperly assessed against exempt hospital property. Additionally, some hospitals make voluntary payments to local governments, such as Phoebe Putney, contributing last year $867,000 back to their county. These tax exemptions exist because hospitals are an important part of the public infrastructure and community benefit. And the main benefits are this: providing primary or specialty care, caring for the indigent, generally referred to as indigent care or charity care, providing health care related outreach to the community, providing in many cases the largest amount of jobs of any employer in the community. In 2010, we commissioned a report by Pershing and Yoakley, one of the Southeast leading accounting and financial consulting firms. Our tax exemption, when we looked at what we would pay in ad valorem taxes versus what we did in indigent care or Medicaid write-offs or community services, was $4 to $1. So there was good value there. Now, we've ordered an update of that report just this past month, and we're going to share it with you, the General Assembly, when it's finished. The preliminary analysis I received the other day, we're seeing return on investment as high as $5.60 in uncompensated community benefit for every dollar in tax exemption. This is due primarily to the rate of medical inflation, which is significantly higher than overall consumer inflation, as well as to greater number of uninsured or underinsured and reduced compensation from Medicare, Medicaid, and private insurers. Our calculation for uncompensated community benefit does not include the additional economic impact on jobs supported. The last thing I mentioned, supporting economic development, is something we've increasingly come to understand. The hospital has a role, as we've seen in 6 hospitals close in Georgia in recent years, often devastating their local economy. When you look at the level of public financing for our healthcare delivery system, I'd say the public is beginning to catch up in their understanding of the need to invest in our system and to invest in our hospitals. The willingness of voters in a number of counties to pass higher margin measures to voluntarily increase their taxes indicates voters understand the importance of their local hospital and they're willing to put their tax dollars to work. Thank you very much for allowing me to be here, and if I can entertain any questions, I'll be glad to do so. I would tell you I had to be in St. Simon's, so I'm going to leave Tim here to answer any questions. So, but I will take some before I have to go to a meeting down there.
Chairman, Monty, does that study about the value of the tax exemption, and compared to hospital expenditures on indigent patient, is the hospital putting what it really costs to deliver the service, or the inflated amount?
The cost.
Okay, so will be what the cost of the service was, not the inflated amount that we often see on our bills?
No, we reported on costs, not charges,
Okay. And the
or
other thing-
inflated.
All right, the other thing is I want to ask you to do something. One of the problems that we're saying, that with sick people and any other groups that want to do it can call my office. We now have had a private partnership, public partnership with a group called Serum. They've got another name here in Georgia, where they are capturing unused medicines, and those will be available by mail to patients who can't afford their medications. They're not going to do a long involved thing. You have to fill out a bunch of paperwork to see if you're eligible. And they have a pharmacy in Gwinnett, but then they will be sending it all over the state. They have just they eased into it with 30 federally qualified health centers six with 30 places. They did a slow pilot run, and now they're ready to go statewide, and it's something we need to get the word out about. So if I get the information to you, will you please?
I would get it out.
To the people.
And I'm glad you mentioned that, because a doctor told me the other day, he said there are 12 prescriptions I can write, and they can take it to Publix, and Publix will fill that prescription free. I didn't know that, but I'm glad to know that, and I want you to know that, because that's a big service. Now, Dr. Kinzel, the way she gives medicine to her patients is she says the pharmaceutical companies are pretty good about leaving samples. Now, she keeps them in the old freezer in the Tasty Freeze, because that's the only thing she has. In the ceiling in her exam rooms is falling in, but it's all she has. She has not gotten a paycheck in 5 years. She will see patients till 7 o'clock on Friday night and go over to Alabama and work the emergency room to make money. So that's what we're faced. And if you have a chance to go to Clay County, I would say Clay County, it's on the West Georgia line of Alabama, Eufaula. And I went through the other day, and it was so sad. The local library has internet connection, but they're only open from 8 to 5. After 5, the school children come and sit on the sidewalk outside the library and do their homework so they get an internet connection. Now, this is rural Georgia. So, well, thank you very much, and I will welcome any of you to come ride with me one day, and let me take you to see things.
County Hospital passed a referendum. I just want to tell members of this council, it's in my district, and it really surprised me that that community passed that referendum. The chamber, every organization in that county got behind that, and they have pretty good access to Macon and other health markets, but they just really wanted that hospital, thought it was very, very important to keep that access in that community, and they're putting their money where they thought it's needed. So
I think that went past close to 70%.
You did. It was very high. So
people want to keep their local.
They really do, Monty. It really opened my eyes that thing passed like that, and those people got behind it. So thank you.
We can do better. We will do better, and telehealth will get us there. I think there's some programs that the federal government has where they'll pay 65% of broadband access. We just have to come up with the 35%. There's a way of doing that without, I think, directing new state dollars. I'll be glad to sit down with you and show you.
Tom McCall. Pull them.
What Robert said, my little old county just added 2.5 meals strictly for the hospital. However, if this stuff goes away that you're talking about in Washington, it's going to cost a little hospital $325,000, which makes one of those meals just go away.
It does, Representative McCall. In fact, I know one hospital that dedicated 3 meals to their hospital, and they're still bleeding red ink.
And we will, but if you don't get the dish,
You,
then
then they're
we
devastated.
get 1.5 meals.
Then they're closed.
Yeah.
Thank you.
All right, next we have Tony Marshall, who's President and CEO of the Georgia Healthcare Association.
I'll let you, and then I've got the mouse right here. Just set the microphone between us.
Sure.
Hey, Chairman, members of the council, thank you for the opportunity to be here. Tony Marshall, President and CEO of the Georgia Healthcare Association, and I have Pam Clayton with me today, who is our Vice President for Quality Advancement and Regulatory Affairs. I learned a long time ago to bring someone with you who knows a little bit more than you do. The second thing I would tell you is, for your sake, my reviews historically have gone along the lines of knows how to take a boring topic and keep it boring. And so I thought I would try to bring someone who can help to change that. As you can imagine today, I know it's in all of your thoughts, but we have been on a number of conference calls yesterday and today with emergency management, and we are working with our centers to prepare a number of evacuations in anticipation of Hurricane Irma. So thank you for all you've done historically to help support regulations, statutes that allow us to have the flexibility to be able to react to these storms. It's quite a challenge. We're not only trying to work with our centers on the coast, but we're trying to work with the Florida centers that are evacuating patients into Georgia. And we're working quite hand in hand with the State Operations Center and making sure that we have efficiencies to do that. We're going to try to attack this presentation from sort of a high-level overview of what's happening in Georgia and drill down into what's happening in the rural communities, and specifically some of the problems and challenges that they're facing, and then answer your questions about what are some of the things that we're doing to keep those centers viable, to allow them to have some level of success, talk about the challenges they face. And then you also ask us to talk about what are some things other states are doing to improve their staffing. And having spent the previous 16 years of my life before I moved to Georgia 2 years ago in Florida, we're going to talk specifically about what Florida did to handle their staffing challenges. And some of the answers are difficult for us to face because they're fairly expensive challenges, but we want to bring those things to the table and let you look at them. Oops. Oh, space. Oh,
okay.
sorry.
Oh, over here, okay. Where is the keyboard? Space.
Yeah.
Or Russell can do it. Russell's gonna do it.
Just sorry about that. So when you're looking today in the state of Georgia, we have 362 centers, 39,700 beds in the state. The rural breakdown is about 145 of those centers are in counties with populations less than 40,000. The remainder obviously being in more urban areas. 13,500 beds are in the rural centers. Treating about 8.6 million Medicaid patient days, a total of about 11.8, almost 11.9 patient days. Again, about 41%, 3.5 million Medicaid rural days, 4.9 million Medicaid or total patient days in rural settings. Number of Georgians between the age of 65 and 84, and we'll talk about that more in detail. It's about 1.1 million in our centers, or in Georgia, and then 85 and older, about 130,000. One of the things that's really unique, Georgia is a fairly low-bedded state. We have a fairly low number of nursing centers per 1,000 elderly over 65. And that's a good thing for the state of Georgia. That means a lot of care is being provided in home and community-based settings, which is the desire of a lot of people, including most all of us. There's 1,881 personal care centers with 30,000 beds. One of the things that's important to note, particularly in rural centers, Georgia's nursing homes may be one of the largest, if not the largest employer in a number of these rural settings. It's about 39,000, a little over 40,000 direct employee FTEs in nursing centers with direct jobs including therapy contract staff, lab staff, other direct staff employed or contracted, of about 59,000 jobs in the state of Georgia, with an economic impact to the state of about $7.4 billion.
So as Tony alluded to some of those numbers that we currently have in our setting, and in the state of Georgia, 65 and older, we anticipate a burgeoning population relative to those that are 60 and over. Between 2010 and 2030, the number of persons 60 and older we anticipate will grow by 1 million persons. That's a big number, and so coupled with looking at the unique challenges to maybe rural settings and the health delivery system overall today, we've got to manage this burgeoning population as well, and how are we going to care for them, provide appropriate services, and when we look at that with workforce issues that we'll talk about a little bit more later on, we've definitely got some challenges that we'll need to address. We're excited about the opportunity to serve Georgia's seniors and to do that innovatively, but there are some challenges associated with those increases in numbers. And this graphic just reflects how that Georgia is expected to outpace the trends, the growth trends compared to the United States overall in those various demographic groups. So you can see that Georgia is really growing in that 60-plus demographic. And this slide reflects persons 60 and older, and comparing us to the Southeast region overall and what sort of growth trends we expect relative to our neighboring states. And Georgia is second only to Florida in anticipated growth for persons 65 and over. And in the 85-plus demographic, Georgia actually leads in the Southeast area. And so, again, we just highlight that because that will bring about challenges and a lot of questions that will need to be answered in response to the needs of those individuals. And when you think about that aging population and what we see trending with Alzheimer's and dementia type diagnoses, how are we going to manage that and do that in a very person-oriented way? And I think it's certainly going to take all of us coming to the table to think about that strategically as well as in a very compassionate and service-oriented way.
When you actually look at the census trends of nursing centers in the state of Georgia, you'll see that in 2007, occupancy in nursing centers was about 90.2%, with about 75% of those individuals being served and paid for by the Medicaid program. And if you come to the most recent data we have available for fiscal year 16, the overall occupancy was down to about 85%, and Medicaid utilization was down to about 72%. And truthfully, this generally reflects the legislature's commitment to improving home and community-based services and expanding availability of programs, particularly through the SOURCE program, in which you allowed the expansion of slots for those home and community-based waiver programs. That clearly reduces the utilization of Medicaid in nursing centers, reduces the budget expenditures for Medicaid, and allows for the SOURCE program to treat people in their home and community-based settings. One of the primary drivers of the ability of centers to be able to continue to operate, as you've heard from other provider groups over the last couple of days, is your payer mix. In the state of Georgia, 72% of all of the residents we serve are Medicaid residents. They're paid for by the state-federal partnership of Medicaid. About 12% is a Medicare. Medicare does pay a profit. Medicaid, you'll hear some specific numbers from us later, but Medicaid pays less than the cost of care each day. And then about 16% are those individuals being served that are private pay, or individuals that come in through the VA or some other payer source, or maybe even Medicare Advantage. That's not captured in Medicare fee-for-service, and that's captured in that category. One of the primary differences, though, that you see between rural populations and urban populations is in that Medicaid caseload. In a rural center, you're actually going to see a Medicaid utilization averaging 79%. And if you look at it and compare that to an urban center with a population greater than 40,000, Medicaid utilization drops down to 68%. So the rural populations, having a greater population not receiving the same level of funding to cover their costs, or having as many opportunities to offset that cost differential with other payers, has a particular challenge that it exists everywhere because of the large volume of Medicaid, but it is particularly challenging in the rural settings.
So Tony just highlighted the differences in the payer mix in the rural versus the urban, and I just wanted to touch on some of the outcomes relative to the rural versus the urban setting, and compare some of those direct care hours and potentially the impact on some quality outcomes. And so you see the rural population in the gray there, and the urban or population of 40,000 or greater in the blue. And just comparing the average composite quality score in those two areas, and the average 5-star rating, and then average productive hours per patient day. And just to touch on what the composite quality score means, what is that? That is a composition of 13 different long stay quality measures that kind of are indicative of the health of some systems within the center. And so it can give us this index of what quality looks like in that setting. And so when you look at the rural versus urban, you can see that the urban setting is trending a bit higher in that quality score. The 5-star rating, I'm sure that many of you all have heard or maybe have even looked at 5-star ratings if you were looking at placement for a loved one. The 5-star rating is comprised of 3 different areas: health inspection score rating, quality measure score, and a staffing component. And then this is rolled up into an average overall rating. And this is weighted against the acuity in each center. And so again, you can see that the urban centers perform just a bit better than the rural setting in the average 5-star rating. And then probably most importantly, when you look at the productive hours per patient day, direct care productive hours per patient day in the rural versus the urban setting, those urban centers do trend just a bit higher in those per patient day hours.
When we look at those comparisons between quality outcomes and the number of hours of direct care, one of the primary drivers is obviously resources. And so what we've done is we've actually calculated the average Medicaid rate for the centers in those less than 40,000 population, shows that Medicaid is paying an average of $167 per day for those centers. In a county with a population greater than 40,000, they're paying $177, a full $10 per day higher than in the rural setting. And you can see in that direct care cost of those actual caregivers on the floor, it's a $68 cost per day for rural areas and at 83.69. Clearly, the resources, when you consider that Medicaid utilization is greater in those rural counties and they have less dollars per resident per day to care for those residents, they have a particular challenge to be able to meet the staffing needs of those centers. What I've included, I'm going to just skip through these real quickly, but I've just put together a cost history from fiscal year 15, 16, 17, and 18, comparing the cost of nursing home care to the cost of, or the payment from the Medicaid system. You'll see in fiscal year 15, we received an average per patient per day statewide of $179. And in the payment, or our cost was $179. Our payment was $166. And then if you go through, over the last 3 years, the legislature has done a good job of funding the cost increases, but unfortunately, you'll see that funding levels has not kept pace with the cost increases. You know, I'm sure you've heard from many other people about the challenges of unfunded mandates. Well, the federal government, as President Obama parted office, put into place the largest regulatory increase in the history of long-term care. And it was effective last year. And so what we're seeing is some of the effects of those unfunded mandates. And they clearly are expecting the state governments and the Medicaid program to pay for those costs. We have to incur them, but that deficit unfortunately continues to grow. And so at this point, we're estimating for this fiscal year 18 that our average cost will be about $194.41, and our estimated payment of the rate increase that was improved this year will be $178, a deficit of about $16.33 per patient per day. One of the things that when I moved to Georgia a couple of years ago that I wanted to take a look at is sometimes Medicaid volume and Medicaid rates can be deceiving if you're only looking at that. And I said, I want to look at the overall margins of all of the centers in the state of Georgia and what are we really able to do. And so we put this together, and when we look at the combined margin percentage based upon Medicaid volume, if you're in a center with 75% or higher Medicaid occupancy, you're averaging 1.3% Medicaid margin. If you're between 50 and 75%, you're averaging 4.3% total volume or margin. And if you're less than 50%, now keep in mind, there's only 20 centers in the state that have less than 50% Medicaid. But if you're less than 50%, you have an average margin or profitability of 8.4%. That clearly shows how difficult it is. What's really important to note is 32% of all of the providers in the state of Georgia are operating at a true negative margin, 32%. So we broke that down for purposes of presenting to this council for facilities and counties with less than 40K. Well, there's only one center in the entire state that has a margin or has less than 50% Medicaid in a rural area, and there's only 27 others that have less than 75%. So it holds true that those margins are higher than the 75% or more, but it's interesting that some of the rural counties' margins, while they're lower staffed, they are lower staffed for a reason. Their margins, to be able to make it, they've not hired as much staff. So while their margins are a little bit better, it reflects primarily either a lack of access to staff, or it lacks an inability to hire them, or frankly, to be able to make the upgrades that a lot of rural facilities need. They have to have the resources to try to keep their buildings, as many of you know, are quite aged in the rural communities. And then we thought this was a pretty important demonstration. If you look at the percentage of revenue that's being provided in the populations, the revenue produced in the greater than 75% Medicaid utilization facilities is 44% of all of the revenues in the state. but it only accounts for their centers only account for 17% of the margin. Those 21 centers that are in the 50% or less margin, or 50% or less Medicaid, they only account for 9% of the margin, but they account for a full 20% of the profitability of the entire state. This sort of gives you, in order to answer some of the questions about what are other states doing in terms of being able to provide for higher levels of staffing, I wanted to be able to provide for you an actual look at what the Medicaid rates of our southeastern states. And this is our Region 4 CMS comparative states. And Georgia's base rate of $155 unfortunately, is the lowest amongst all of the Southeast. That additional red is the 1710. This is the nursing home version of the provider fee that the hospitals talked about earlier. And this is one of those that, while you have to have technically on a piece of paper a loser, the reality is it provides for a higher Medicaid rate for every single center in the state. And while that 20 centers that are with very low Medicaid margins are paying more in than they get back through Medicaid, the reality is they're still the most profitable, and their differences, they still, by having less Medicaid, make money. So from a net perspective, there are no real losers in this program in the nursing center.
Okay, and you might be asking, why do we think it's important to talk about the Southeast region as a whole when we're really contemplating this rural versus urban question? But from a quality standpoint and care outcomes, when I think about centers and their performance and the individual patient outcomes, I have to ask myself, what things are the same and what are those differences? And so I think that's why it's important to look at this Southeast region, because we would anticipate that disease profiles, culture, dietary preferences, and that sort of thing would be similar in the Southeast region. And so if that holds true, then how do those outcomes compare? And this slide here, it's a little bit busy, but it is comparing Georgia to the nation and the other states in the Southeast region in total direct care staff per patient day hours, and also comparing that average 5-star rating. And I really hate to say that Georgia, you see in the far left here, has the lower 5-star ranking, but they also have the lowest direct care staff per patient day. And so I think we have to recognize and acknowledge that there is likely a relationship there. If the other states in the Southeast region are probably treating similar residents and patients, what are those key drivers that are resulting in some of those differences? And again here, this just shows you average 5-star rating, as well as the different 1, 2, 3, 4, and 5-star percentages in each of those different states. And again, Georgia is over here to the far left. This talks about, again, the direct care FTEs and direct care productive hours. So we really wanted to look at who is at the bedside and who is really out there taking care of the patients, and how does that compare relative to those other states in the Southeast area. Also, again, comparing to the 5-star rating. And again, Georgia is over here to the far left, indicating the lower PPD as well as the lower star rating. I am pleased to share, and this is something that all of you can be very pleased about, Georgia holds the distinction of having the longest running statewide satisfaction measurement and improvement program in the U.S. A lot of other states across the nation have looked to Georgia and said, tell us about your quality incentive program, your satisfaction surveys, and how you have done that. And despite the fact that we have some lower staffing PPDs, which we have to acknowledge, some of those star ratings are not as high when you compare to other states across the nation. Our patients, families, residents tell us they're satisfied. They tell us that you're doing a good job, and I think that probably speaks to the heart of the nursing centers and speaks to that level of hospitality as well as care and compassion that we seek to provide. But when you look at the fact, and this is by a third party that was conducting the survey, and there were over 17,000 responses, greater than 35% of the residents that responded rated their center as a 10. That's pretty impressive. I probably, on any average day, I don't know that I'm going to be rated a 10 on anything. And so when you can get that sort of a percentage, I think that's impressive and certainly something for all of us to be proud of. And when you look at the families, and we know that expectations continue to grow, 93% of the families that responded said they would definitely recommend the Center for Care. And here, this just depicts that Georgia, once again, leads the nation in the number of Excellence in Action Awards that were presented to centers as a result of the satisfaction survey outcomes. And this just means they fell in that top 10% as far as best outcome in different categories. And as you can see, there were a lot of centers that were recognized as delivering excellent care. And I do think that's something to be proud of. So we've talked about a lot of different numbers and kind of hit you with that, I know, and we appreciate your patience in that. But what do they tell us? So what do we know when we're talking about health care in the post-acute care setting, specifically long-term care? What do we know? And that is, there's a validated correlation of resource to quality. So the skilled nursing centers or the states with higher staffing levels and reimbursement rates demonstrate improved quality outcomes. So I mean, we've shown that very clearly, and that's not a subjective opinion, that's very clear. And we know that payer source is a greater predictor of quality outcomes than other factors such as geographic location, though we know that, as with anything, it's multifactorial. Those quality outcomes are multifactorial. We know that consumer, legislative, and oversight agencies' expectations for value-based purchasing continues to grow. So it's sort of that, and you probably feel this every day, that more with less. And so there's the expectation that you get the best quality outcome in the least or shortest amount of time with the least amount of resource in the most efficient way possible, that value-based purchasing. The volume of admission of discharge in patients has dramatically increased related to this focus on home and community-based services, and that desire to serve the patient in the lowest cost and lowest level of care setting possible. So what does that mean? Patient migration patterns and acuity have significantly impacted clinical operations in our setting. You know, 15, 20 years ago when I was a director of nursing in a skilled nursing center, I might have admitted 10, 15 patients a month. Okay, so that was a normal admission pattern for me. And now that's occurring, you know, some centers might do 5 to 10 admissions per day. When you talk about the impact on your clinical operations and your operational model overall, and that ability and the expectation that you be able to admit 24/7. You know, back in the old days, we might not have taken an admission after 5 o'clock. That's no more. You're expected to be able to admit at 11 o'clock at night if that's what the hospital needs. And so that's had a significant impact on clinical operations, and that holds true in the rural and the urban areas. And then, as Tony alluded to, these unfunded mandates and the necessity of enhanced clinical competency relative to this increasing acuity. So we serve patients today and residents today in the skilled nursing setting that 10 years ago might very well have been in an ICU in the hospital. So it has dramatically changed. And so that brings to bear some of those acute workforce challenges that we are experiencing and we will continue to experience across the state as we think about health delivery and other issues. Nationally, projections indicate that more than 1 million direct care workers will be needed by 2018. Gosh, that's next year. And obviously this was something that was looked at a few years ago, but that need is definitely upon us. And as I talked about that admission and discharge patterns in the nursing centers, discharging to home and community, looking at those really solid handoffs for the best possible outcomes. More and more social workers are needed in our setting, and there's a definite shortage there as well. And by 2020, the nursing workforce is expected to drop 20% below projected requirements. That's a number that gives me a significant pause and really could keep me up at night. So when you think about that burgeoning aging population and those workforce challenges, this is out from the Georgia Department of Labor's 2016 annual report. It's striking when you look at this. 18 of 25 of the fastest growing occupations in Georgia relate to healthcare. So I mean, we really have to digest that and be thinking about how do we address this. And this is just another graphic. This was showing job postings and registered nurses was the second greatest in number for job postings. So it tells me, you know, the jobs are out there, we're needing to hire, and we're challenged to find those nurses to fill the positions. So we talked about, I think one of the questions was, what are you doing? How are you responding to some of these challenges in the rural healthcare setting and really across the state as a whole in our setting? I'm pleased to say, I think we've been very innovative and really have come to the table with other providers across the continuum looking for solutions and innovations in care delivery. Over the past several years, we've certainly enhanced our telehealth capacity, really specifically in rural health settings as well. I think you maybe had Paula Guy with GPT here yesterday and Dr. Jean Sumner. And Dr. Sumner was a champion for telehealth utilization in the skilled nursing setting, and she really could model such great outcomes in utilization and maximizing that in our setting. However, we're challenged because to go in and develop the infrastructure to allow you to do telehealth effectively in a rural health setting is challenging because of that bandwidth issue. And while we might go in and drop T-lines and all that technical stuff I don't know anything about, oftentimes what happens is you only have one area in the building where you can conduct that telehealth visit, and that's not really ideal for patients or physicians. Certainly we encourage top of license practice, and what that means is we need nurses at the bedside delivering that skilled care, and those folks that those things that would not require a license, that we would have individuals offloading some of that burden so we can have nurses focused at the bedside. Care coordination networks, these have been really effective in a lot of areas where the providers across the continuum are coming together and they're saying, okay, we need to look at readmissions to the hospital, or we have a particular diagnosis that's challenging us, what can we do? And we've looked at those care coordination networks. So perhaps a patient was in the hospital and they discharged to the skilled nursing center, and then they discharged back to the community. But about 7 days after that, they are starting to have some issues, and they go to the emergency department. So we worked with the emergency departments in a lot of areas to say, don't readmit them to the hospital, admit them back directly to the skilled nursing center, and we can provide that care and avoid that hospital readmission, because certainly that cost factor in getting that best possible outcome in that lower level care setting is ideal. And we even will directly admit from home health when we have those care coordination networks. And certainly aligning service models with community and health system needs. So if a particular hospital or health system is challenged with a level of care, maybe ventilator care, maybe ventilator